Hello, good morning, ladies and gentlemen. Would like to thank you for joining us this morning for our Faith Community Initiative Partners Forum. And the title, Engagement of Faith-Based Organizations, CBOs and Private Not-for-Profits to Support and Sustain HIV Epidemic Control in the Republic of Uganda under the President's Emergency Plan for AIDS Relief. We are about to get started. Official startup time is 9 a.m. We thank you for keeping time. Please allow a few more minutes as more guests join us and more members log in. For our Zoom audience, you're most welcome. We are streaming live from Inter-Service Hotel in Zambia. Like to thank you. Please stay on board and we should be starting officially shortly. Thank you. A few ground rules before I break off. A few ground rules. Please mute your microphone. You're free to turn on your video. There's no problem, but please make sure your microphone is muted. We don't want to have feedback and interruption of this meeting. And in case you have any comment, you could also jot it down in the chat. If you have any, you want to make a submission, please raise your hand with the controls in the Zoom application. We will be very glad also to know who you are. We request you to just write your name and the title and the institution that you represent in the chat, and we shall recognize your presence in this meeting. Thank you once again, and we will be back shortly. Thank you. Welcome back. Once again, I would like to thank you for logging in, and we're going to start our program with an opening prayer, and then we'll have introductions so we know who is on the call and who is in the room at Inter-Service Hotel. And I would like to request us to humble ourselves for a word of prayer, and we get right into our meeting. Let's humble ourselves. In the name of the Father, the Son, and the Holy Spirit. Amen. Heavenly Father, we thank you for this morning. We thank you for convening us together as members of the faith community, partners, and friends. We pray, Lord, that you will guide this Partners Forum, you'll guide our discussions, and you'll bless all the plans that we have and enable us to accomplish them to the best of our ability for the glory of your name as we serve your people. Glory be to the Father, and to the Son, and to the Holy Spirit, as it was in the beginning, is now, and ever shall be, world without end. Amen. In the name of the Father, the Son, and the Holy Spirit. Amen. Once again, I would like to thank you. I know we have catechists on the call, we have religious leaders, but I took the honors of leading us in the opening prayer. My name is Patrick Mbusa, and I'll be your MC. I request those on the call to mute. Please mute your microphones. We don't want to get feedback. So we'll go right into introductions. We are glad as Uganda Episcopal Conference, Uganda Catholic Medical Bureau, to host you this morning for the Faith Community Initiative Partners Forum. We shall begin with the members that we have right here in the hall, introducing ourselves to you. So I'll request those in the hall to just, in order to unmute your microphone, there's a button that you just have to press, and then you speak, and then you press the same button to mute it as we introduce ourselves.
Thank you, moderator. Good morning, everybody, and I welcome you also to this Partners Forum. My name is Justus Muhanji. I work with the Uganda Episcopal Conference, and I lead the Strategic Information Team. Glad to be here.
Nsanyuse nnyo okubeera wano mu kifo kino mu lukiiko luno olwa Episcopal Conference. Amannya gange bampita Musomesa Donata okuva e Lwamagwa Parish, Masaka Diocese.
Welcome all. I'm Migadepo Richard, the leader Menis Gilidi Kaboko Parish, Masaka Diocese. I'm happy to be in this forum.
Good morning, everybody. I'm Moesezi Henry. I work with the Uganda Episcopal Conference. I lead the team in the Masaka region. I thank you.
I'm Ronald Kamara. I work for the Catholic Medical Bureau. I coordinate the Kampala HIV project plus the FCI project. Thank you.
Good morning, everyone. Muluya Rehema is my name, and I work with Uganda Orthodox Medical Bureau, coordinating the FCI project as project officer, Luwero Dinari. Thank you.
Good morning, ladies and gentlemen. I am Sechimpi Kirwana Lawrence. I head capacity building, quality improvement, and learning agenda. Thank you.
I'm Dr. Sam Orach, the Executive Secretary of Uganda Catholic Medical Bureau at the Uganda Catholic Secretariat. Thank you.
Thank you for those introductions. I would like, in a special way, to welcome the Ministry of Health. I know we have some members on the call from Ministry of Health. I request, if you're on the call from Ministry, please kindly unmute and just introduce yourself. Okay. Ministry of Health, yes, thank you for that. We have more members from the ministry. Okay, I think I will introduce Mr. Edward Kato when the opportunity comes, but I can see he's on the call. You're most welcome, and all staff from the Ministry of Health. I would like also to recognize the presence of our donors, the United States government team, specifically from CDC, Centers for Disease Control and Prevention, on the call. I'll kindly request you to unmute and introduce yourself. You're most welcome. Thank you, CDC team. You're most welcome. And we also have representatives from the other medical bureaus: Uganda Orthodox Medical Bureau, Uganda Muslim Medical Bureau, Uganda Protestant Medical Bureau. You're most welcome. I would like also to recognize the presence of the staff from UCMB, the host, and the UCMB and other medical bureau facilities represented on this call. In the interest of time, I will request to introduce the groups present, as I have done, so that we can save time and proceed with this meeting. We apologize for starting late, but we wanted as much attendance as possible. You are most welcome. Right now, allow me, ladies and gentlemen, to move on to some opening remarks from Uganda Episcopal Conference, Uganda Catholic Medical Bureau, which will be given by the Executive Secretary, Dr. Sam Orach. And he's going to speak on behalf of UEC. Ladies and gentlemen, Dr. Orach. Thank you.
Good morning once again, ladies and gentlemen. I basically really want to welcome everybody and appreciate you all for coming to this Partners Forum, whether physically here or online. I recognize all those who have been introduced: Ministry of Health, CDC, our funder for this project, the other medical bureaus with whom we have worked and their facilities, particularly the Muslim Medical Bureau, the Orthodox Medical Bureau. I want to thank those facilities that have participated in this project that we started implementing 1 year ago. The Faith Community Initiative project is in itself an innovation. It was what I would call a design and build project, an initiative that we picked, we designed, and implemented. Today we are sitting back to take stock of what we have been doing in the last 1 year, but it's also time when that project and 2 others are being subsumed into a new one. Just 2 days from today, we will be starting a new project that will incorporate elements of what we have been doing in the FCI project, but also other components. I want to say that we look back with happiness that we were able to design and build a new initiative from which we have made a number of achievements that are going to be presented today. But we have also learned quite a lot. That learning has given us a capacity. It was a capacity building for us because we got new knowledge, new insight, and new conviction in the methodology of working through the faith community and other community members. I want to thank CDC for having supported us in this project through the funding, but I also want to thank the other partners who have worked with us in the other projects in these same regions. The FCI project covered the Catholic Church dioceses of Masaka, Kinda-Mitiana, Kampala Diocese, and Kasana-Luero Diocese. And in these areas, we have also had the Kampala HIV/AIDS regional project, as well as the Masaka regional project, funded by CDC through the Rakai Health Sciences project. And that's why I want to thank Rakai Health Sciences project and IDI also a lot. We believe that the proceeds of the FCI project, especially demand creation, knowledge creation, have also benefited these other 2 projects. As we move on into a new phase, a new project, it is only a project or projects that are transitioning, but we have been able to establish or strengthen relationships, strengthen partnerships that we want to see moving forward, that will enable us to collaborate in many other ways in the future. As to the other medical bureaus, the Muslim Medical Bureau, Orthodox Medical Bureau, with whom we worked, as well as the Uganda Protestant Medical Bureau, who implemented a separate program under the FCI. This is simply part of our interbureau coalition, and we want to use the proceeds of this to strengthen our collaboration as medical bureaus. We are getting out in this transition from some of the facilities, particularly the ones of the Orthodox Medical Bureau and the Muslim Medical Bureau, that will be supported in this next 1 year directly by the implementing partner, IDI, that has been supporting us through funding. However, we know that these medical bureaus are faith communities like us. We have a lot in common with them. And if allowed, we are willing to do a lot more also with them in the future. I will not take too much time because the gist of this is to come and take stock of what we have been doing in the last 1 year, but also to share the experiences and lessons from it. So I only want to wish everybody a good participation, good listening to the presentations, and good discussion. God bless you all. Thank you.
I'll request those in the room to make a round of applause for Dr. Sam. Thank you so much, Dr. Sam, for making remarks on behalf of UEC. And ladies and gentlemen, we have quite a number of presentations, and I'll just run through them so we have an idea of the presenters we have scheduled for today. We will be having remarks from Ministry of Health made by Mr. Edward Kato, but that will come later because we understand he has another commitment, but he will be joining us to make remarks on behalf of Ministry of Health. We shall also be having remarks from CDC, our donor, and then specific presentations from the FCI project, in which we will showcase the achievements that have been made in different aspects of HIV epidemic control. We shall have testimonies from the beneficiaries of this project, community carers. We shall also hear the voices of the religious leaders. We also have on our schedule presentations highlighting our role in addressing violence in form of gender-based violence, violence against children. We shall showcase our gains in finding the missing HIV-infected persons, specifically men and other hard-to-reach groups in whom case finding, if I may call it, or testing rates are still lagging behind. We will look at methods of data mobilization and use, and then we will also hear the voices from the other medical bureaus, UMMB, UOMB, and our partner, Uganda Empowerment Mission. I'd like to use this opportunity to welcome UGEM as well to this meeting. And then we will also listen to the views of religious leaders with regard to epidemic control. So in a nutshell, that is the roadmap for today's events. And I'd like to once again welcome you and to use this opportunity to move on to a presentation that will showcase an overview of this project. As we had the remarks from the Executive Secretary, we've not done this alone. We've worked in partnership, and so far, a lot of ground has been covered. And as he mentioned, in 2 days, we shall be going into yet another chapter, if I may call it, of the FCI implementation. And we would like to thank the US government, the Ministry of Health, for putting faith in the faith structures. If I may put it that way, you put faith in the faith structures that they too have a significant role to play in the fight against HIV/AIDS, the fight against death, the fight against stigma, the fight against injustice. And we are committed as the faith community to put the people first, to put the person and address their needs specifically and in a holistic manner. So I would like to thank you all the way from the US, from the US CDC in Atlanta, OGAC, for this initiative, and we believe that we are moving on the right track. When we look at the epidemic control agenda, it has to be holistic, it has to be universal, and we should not only look at the body, but we should also look at the spirit and the soul. So ladies and gentlemen, I sound like I'm speaking too much, but I am just overwhelmed with joy that we have this opportunity, and we'd like to thank you. So at this juncture, I would like to invite my boss, if I may say, Mr. Ronald Kamara. He is the program manager for the Faith Community Initiative, and he's going to give us an overview of this project. Ladies and gentlemen, Mr. Ronald Kamara.
The principal investigator and executive secretary of the Catholic Medical Bureau, Dr. Raj, colleagues from the Ministry of Health, our partners from the Centers for Disease Control who are supporting this project, our colleagues from the sister medical bureaus within the fraternity of believers, our colleagues we work with in the different dioceses during the implementation of this project, and my colleagues in office at the Catholic Medical Bureau. I would like to warmly welcome you here to this Partners Forum. I'm going to share an overview of the project very briefly in the allocated time. It is going to be loaded up in a moment. There it is. And in this presentation, I'll take you through what informed this project, what the project was supposed to do, what it did, and some of the key lessons that we have learned. My other colleagues will take you through the specifics of the achievements. As you all know, in this country, men continue to be a major driver of new infections, new HIV infections. And men have to be specifically reached in their specific areas where they can be reached comfortably with messages and with HIV services to ensure that they get to know their status and they are enrolled into care. HIV positive men, especially those between 25 and 39, have been noted to have low rates of diagnosis, treatment, and virus suppression than the women. Well, of course, we are all aware of the other epidemic of multiple and concurrent sexual partners that has continued to drive new infections in this country. More men, as I have mentioned, have been hard to reach. So many men like me and you might be living with HIV unknowingly, and for some reasons we are hesitant or we are shy about going for an HIV test. Children and adolescents also have been particularly difficult to reach with testing services. And sadly, we still have pockets of stigma in this country that have continued to slow down our efforts of hitting the 95, 95, 95 goals. We know very well that also violence against children continues to be one of the structural impediments to access to care. And the VAC survey of 2016 showed that we have unacceptably high levels of physical, emotional, and sexual violence against children. Girls are more disproportionately affected by the violence, hence predisposing them to the risk of acquiring HIV. And sadly, by the age of 15, 24 years, that survey showed that HIV-positive girls were 4 times the number of HIV-positive boys. This means that we have to specifically also reach out to these girls with messages, with programs that enable them to be safe and enjoy their rights like any other citizen in this country. That was the background to the FCI project, whose purpose was to engage faith-based networks to rapidly increase the proportion of men and children living with HIV who know their HIV status, link them to care, and have them suppressed. Given that background, and given the role and the reach and influence of the faith communities, not only here in Uganda, but in sub-Saharan Africa, we think that FBO communities can play a very big role in helping to reach out these men and helping also to promote and ensure justice for children in as far as it inhibits their access to care. The strategic approaches of the project were 3. 1, building capacity of these FBO networks, religious and lay leaders, on current HIV programming and demand creation. You all know that we have lived with HIV in Uganda for a very long time, almost 4 decades. And right from the early days of the epidemic, faith communities were at the heart of messaging, at the heart of demand creation, and at the heart of care in this country. But HIV is dynamic. There are dynamic changes that have happened that require new responses to managing HIV and preventing its spread. And these dynamics need to be known by the religious leaders. They need to be prepared, and they need to be capacitated to play a bigger role if we are to hit epidemic control. The other approach is HIV testing, linkage and retention for men, children, and priority population increased through faith platforms. The desire of this project was to see to it that we extend HIV testing services to the specific subpopulations of interest in their ordinary milieux. Given that they are slow in coming to get HIV tests in the health facilities, the project wanted to reach them through the faith platforms, but find them where they are, or use our premises of worship, premises of congregation, to bring men there and other subpopulations of interest to access services. The third approach was to improve the coordination that we have with the other national and subnational structures and systems. This project, as the principal investigator mentioned, has been implemented in the three CDC-supported regions of Masaka, Mubende, and then Kampala, Wakiso. And we're happy. We have had some good working relationships with the comprehensive IPs that are supporting HIV services in those regions. And we have used the districts, the 22 districts there as planning units. We have been able to work through our faith platforms, the parishes, the mosques, and other structures to reach to the people that we wanted to reach. We have also collaborated with targeted high-volume facilities in those regions. We had targeted 45, but we worked with about 39 to ensure that the community facility linkage framework is implemented appropriately in as far as it helps to achieve objectives of the project. We did collaborate with the Ministry of Health. They have been very supportive in supporting this project. We have been working with them very closely, and I'm sure Mr. Kato will, in his remarks, share experiences of working with us on this project. We have also, as mentioned, we have worked with our sister medical bureaus, the Muslim Medical Bureau and the Orthodox Medical Bureau in particular. And also we have worked with the other above site mechanisms, especially the SBCA that has supported our material development. We have also worked with other CSOs, especially UGM, that has supported the project in penetrating certain subpopulations that would have been difficult to reach ordinarily. We have also worked with and through media houses that are owned and run by the faith communities in sending out messages of hope through different media programs on radio. We've had a number of talk shows and sport messages that have contributed greatly to the demand creation of this project. Arrangements through which this project was implemented, we subgranted to the 2 medical bureaus and also to the Catholic Center for Legal Aid Services that helped a lot in accessing justice for the children that have been subjected to untold violence through the wide network of the Catholic Church's Justice and Peace Network. We also worked with a CSO, that or a national NGO, the Uganda Empowerment Mission, that helped a lot in working with our faith structures, in reaching out to subpopulations, especially the priority populations and some key populations here in Kampala, Wakiso, to also access services through this project. We have also been closely tracking and associated with other partners that are implementing this FCI project in other countries. Through the FCI Secretariat, we have had bi-weekly webinars with people from other countries to learn from them on how the faith structures and faith systems there are contributing towards their respective country epidemic control efforts. We have also worked closely with regional implementing partners, especially Maldimay, Rakai Health Sciences Program and IDI, and other PNFP facilities for referrals. We have generated and also made use of other IEC materials from the Ministry of Health, especially to support our demand creation activities. We have also worked through our structures and systems inspired by faith to build capacity, as I said, on current HIV knowledge and dynamics of transmission and management. We have also been happy to support an army of peers in the community, caregivers and frontline faith leaders. As you know, many of you might be in different faiths, and you know those leadership structures in communities. The head of the laity, the head of married couples, mothers' union, fathers' union. In the Muslim faith also they have theirs. And these are the frontline actors with whom we have worked to penetrate the targeted subpopulations to ensure that they receive appropriate services. We have also worked in particular with religious leaders, and I want to thank all the religious leaders, the priests, especially that have supported this project in the Orthodox Church, in the Catholic Church, and also the imams in the Islamic faith. And these have particularly played a very big role in creating demand for HIV testing services, including HIV self-testing, through their summons, through their messaging, and these have contributed greatly. Especially in the Islamic faith, they even went as far as generating, through this project, kutubas or messages or sermons that were used by imams to raise awareness within the congregants about HIV issues, and also to create demand for HIV testing services. My colleague Lawrence will take you through the HTS cascade in another presentation to show you the numbers that we have been able to reach and link to care. We have also been able to identify several underorganized men and children who would not have had access to an HIV service, or who would not have known their HIV status if it wasn't for this project. We have also worked hard through the clergy to destigmatize HIV and try to, to understand it as any other health condition. We have created awareness about TB and other referred clients for TB treatment and prevention through the network of the PNFPs that we've been working with. We have also worked with the other HIV service providers to popularize differentiated service delivery models through messages of hope, whereby people can access services in a manner and mode that is most convenient for them without necessarily coming to a health facility. We have also supported demand creation for some other services like PrEP, VMMC, and post-exposure prophylaxis for those that have been victims of violence. And also, we are happy we have contributed through the clergy to some of the adherence to treatment and virus suppression in those regions where we have been working. And we have also been able to create awareness and referrals for GBV and VAC to appropriate authorities. Other aspects of our implementation arrangements, we worked with the large volume sites that I've already mentioned, and we treated the surrounding adjacent faith communities, parishes, and mosques as partners with the targeted health facilities, so that the clergy and the faith leaders could identify and select leaders within the upper and lower tiers for training and to support the demand creation and mobilization activities, looking at the health facility as the hub where these services could be got, or where they could be picked from and then reach them, the communities. The focal persons that we identified in each of the faith communities to supervise, and they were very instrumental in linking the community and with the caregivers within the health facilities. Religious community carers offering one-on-one counseling through we created some safe spaces in some of the houses of worship where people could congregate and have access to a counselor, have access to some counseling service and psychosocial support through the house of worship nearest to them. We also worked with the health facilities that I mentioned earlier on to support us with commodities, especially HIV self-testing kits, and also building the capacities of our community carers to effect appropriate community and facility linkages and referrals. The health facilities also were helping to record our referrals in their registers in order to determine and show the additionality that this project has been able to achieve in conjunction with health facilities. The health facilities also have been very instrumental in helping us access other services. I know that in some of the areas there we've been working, we worked with the the district authorities to expand vaccination drives within the faith communities. We also, in one or two of the parishes, had activities of the men and men's guild, where they were able to access other health services and screening for NCDs and other conditions, which would not have happened if it wasn't for this project. So we were able also to work with the facilities to identify and notify faith managers for right interventions. They bring back to care and support the country's prevention efforts. And also deepening service delivery through the health facilities by working with community structures of the religious establishments. On the access to justice front, we work with our sister department at the Episcopal Conference, the Justice and Peace Department, with the support of the Catholic Center for Legal Aid Services, on access to justice, on sensitization on issues of rights and responsibilities in the context of preventing violence against children and managing or supporting victims of such violence to access justice. Then we also had faith-led engagement with law enforcement agencies, where we encouraged our religious leaders who ordinarily come across people that have been subjects of different forms of violence, to help them to access law enforcement agencies and other legal aid assistance through the Catholic Center for Legal Aid Services. Lessons learned. Allow me to share one or two slides on the lessons that we have learned, in the hope that they can inform further programming and further engagement with our partners. One, religious structures, if facilitated, can play a bigger role in the country's efforts towards epidemic control. And this is not restricted to only finding men, but also
recording in progress.
Adherence and retention systems for people that have been very difficult to keep in care. What's happening there? It seems the technology is becoming more complicated. The other lesson is that there are synergies between faith structures and health facilities that need to be optimally utilized. Faith structures can work with the facility-based healthcare providers to bring back patients to care, to support other non-clinical services, including psychosocial support, access to justice. And we are open to this open collaboration and further engagement to see to it that we make use and optimize those synergies. Another lesson we have learned is that we may need to deepen HIV mainstreaming in the work of church agencies. Here we mean, if it is our pastors, we would like to see to it that our pastors play a bigger role as part and parcel of their pastoral work, preaching, teaching, to also include aspects of HIV messaging in the sermons and message and the teachings that they give to the faithful and their congregants in the different areas. Most importantly, in some of the churches where we have nearby health facilities, we'd like to strengthen those bonds of collaboration, even for other health services, like screening for NCDs, vaccinations, immunizations, but also giving health talks in church. We think this project can open up new boundaries of health promotion in the country through working with faith structures. 4, we have learned that we may need to strengthen our partnerships with other CSOs. There are some of the services, especially services related to reaching key populations, which might be hard for faith structures. And through our engagement with one of the CSOs, we have realized that with better partnership and better collaboration with these CSOs that serve these communities. They can act as gatekeepers, mutual gatekeepers to enable the pastors reach the key populations, but also to enable the key populations also reach the pastors. So we think that this partnership with UGAME and other CSOs needs to be strengthened to be able to open up new space and new horizons of engagement. Then FBOs have a lot of media houses, and as you know, many of our media houses have a lot of talk shows on politics and other earthly things. But we think that these media houses could be supported, and our experience has been working with Radio Sapiencia, working also with Centenary Radio in Masaka, but also working with one of the Islamic radio stations through the Uganda Muslim Medical Bureau. We have done a lot of health promotion and demand creation through the mass media, and this is something that we think needs to be supported to continue. Finally, I would like to express our gratitude to the Catholic Bishops' Conference that has given us an opportunity to serve God's people through this project. We are committed to continuing to serve in the spirit of imitating Christ's deeds. We want to thank CDC that has funded this project, and we trust that we are still together, and we trust that we can continue to do more and better with further support. The Ministry of Health, for your guidance, we thank you very much for the technical assistance and also for the materials. The ministry has a lot of demand creation materials, treatment literacy materials for community leaders. Even right now, there is a process going on in Entebbe where part of our team is participating jointly with the ministry and other actors to develop other materials that are going to be shared with you in the course of next year. We want to thank the districts that have supported us in this project, and we want to thank other IPs with whom we've had a very good synergistic relationship. Thank you very, very much, and may God bless you.
A round of applause for Mr. Ron Kamara, a program manager. Thank you very much, Ron, for this expose, a very elaborate but succinct summary of the FCI project. You have very ably given us a 360-degree view of what has been achieved so far, and we are very grateful once again to all the partners who have made this possible. I would like, in a special way, to recognize on the call our religious leaders from the different denominations, from the Orthodox Church, from the Muslim community, from the Protestant, and from the Catholic community. I would like to recognize the other comprehensive implementing partners that Ron mentioned, IDI, RACI, Health Sciences Project, and Mild May. And our partner, Uganda Empowerment Mission, you are all most welcome. We have a big attendance on Zoom, and we are glad that you've all taken the time to be a part of this FCI Partners Forum. Ladies and gentlemen, as the program manager presented, a lot has been achieved, and this couldn't have been possible without partnership and without working communally for the same cause. Finding the missing men, justice for children, creating demand and supporting day-to-day HIV service delivery in the entire cascades, from testing to treatment and to supporting the treatment. At this juncture, I would like to give you an opportunity. If you have any questions or comments, feel free to jot them in the chat. We have someone who's monitoring the chat. And I would also request that if you are on the call and your name is appearing, for example, as Techno, iPhone, or itel, please rename yourself. We shall be using the participants list as a record of our attendance. And I would like to know who you are. Just put your name and then the institution that you're representing. I'd also like to apologize. We got some feedback that there was echo at some point in the call. We do apologize for that technicality, but it has been addressed. We are reliably informed. It is now clear. So without further ado, we'll just have one more presentation before we take a tea break. And we're just going to understand all these achievements that have been presented. What are the methods that we have used as the FCI project to mobilize the communities and collect the data that shows that actually this intervention is working? So I would like to invite Mr. Justus Muhanji, who is in charge of our strategic information, to kind of take us through what we've been doing, what has it yielded, and what impact have we been able to achieve in a very short time. So while the presentation is being loaded, I would like you to, once again, feel free, write in the chat. We will read out your comments. If there's anything that has been discussed so far or presented that's not clear, you're free to ask for any clarification or any questions specifically that you'd like us to address. Ladies and gentlemen, we are going to have methods and mobilization of data under the FCI project, presented by Mr. Justus Muhanji, the Strategic Information Advisor. You're welcome.
Thank you, moderator. Good morning once again. My name is Justus Muhanji. I work with the Uganda Episcopal Conference and I lead the strategic information team. This morning, I would like to share with you, just to give this a little bit of brief, picking on from what the program manager has presented to us. And since I'm alone up here, please allow me to remove my mask. It is making me very uncomfortable. And what I want to share with you this morning is the path through which our mobilization activities went and the partnerships that we've engaged and the capacity building and any other follow-up and support activities. We did the mobilization and engagement at national level, where we had the engagement with bishops of the different denominations, the Mufti of Uganda, the Metropolitan, the late John Arwanga of the Orthodox Medical Bureau, the medical bureaus of the different faiths. And then we went down to the regional levels and engaged the faith leaders at that level, and up to the community level, where we had the community level leaders engagement, the catechists, the lay leaders, the mwalimos, the heads of the twales, and other community faith leaders who are the foot soldiers in making sure that this project works and works well. The other aspect is the partnerships, and the partnerships is at two levels. We had partnerships within the faith-based space. We had partnerships with the Center Catholic Center for Legal Aid Services, the two medical bureaus, the Uganda Empowerment Mission, whom I hope is online. Then we had our partnerships with the media, particularly the two Catholic radios and one Muslim radio station and television, Bilal. And then we had partnerships with the Ministry of Health, as outlined by the program manager, with the regional IPs to support the various aspects of the project, and then the USAID partner for messages. And at national level, we had the different faith leaders. You can see our engagement with the Metropolitan and the different bishops of the Catholic Church. And after mobilization, we did a lot of training, and I think you can see in the lower left corner, the Metropolitan was busy attending a training of the governing council of the Orthodox Church. And in the upper picture, we have the training of the Muslim sheikhs and Muslim leaders in one of the regions. And then in the right-hand side, we had trainings of the community faith leaders. And the bottom right corner, we had the training of the Radio Sapienza staff, just to make sure that everybody understands the message the same way, everybody understands the objectives, and we all pull together. We had direct engagement. We used every opportunity in church. We used the faith leaders to demonstrate how HIV testing works, so that the laity and the followers can see and take it on. And then we had hands-on demonstration on how to record the data that is the faith leaders are working with or generating from the community. We had, again, here is another demonstration of our engagement with the media, where we had the priests come to radio stations with our staff to make sure that we pass on the messages of hope and also educate people on the various aspects of the project. And Lawrence is going to give deeper outputs of the project, but I just wanted to mention that we had at least 7 radio talk shows, 420 radio jingles, 308 DJ mentions, and over 570 sport messages running on these various media platforms. Later, the Muslim Medical Bureau will also be giving us some more details of the engagement with TV and Radio Bilal to show you more of what we've been able to achieve in this 1 year. We've done, to make sure that things work, we operated in a COVID environment. So we went ahead to do support supervision of the faith leaders in the community, to do data quality assessments to make sure that the data they are collecting is meeting the standards. We provided test kits, bags, t-shirts, books for recording, but more importantly, we equipped the community carers with COVID-19 PPEs to make sure that they are safe and protected, and they also protect the people they are serving. We worked with the ministry to make sure that we provide the handbooks for the faith leaders. And I just want to show the faith leaders handbook that we worked very closely with Mr. Kato at the ministry and other partners, CRS, the Clinton Foundation, and PEPFAR that supported the development of these materials. So these are available and in the hands of the people that are leading the interventions in the community. And we hope with this, the sustainability of these initiatives is assured. Like I mentioned, the number of faith leaders that have been put together, 499 across the project. There's 37 faith facilities that we are working with. The 195 community level faith leaders that are leading the activities, and the STTAs, the 18 STTAs that are supervising at the community level and supporting the community carers to make sure that things are happening, and the tools, the data collection tools that have been provided to track, to record, and report outputs of these initiatives. This is just a summary of what I wanted to share with you, and I thank you so much for listening to me, and have a great morning. Thank you.
A round of applause for Mr. Justus Muhanji. Thank you so much for taking us through the more detail on the mobilization strategy and how we have got to where we are so far. Ladies and gentlemen, I would like to give you an opportunity once again, if there's anything that's not clear or you feel needs more elaboration, please feel free to put it in the chat, or if you have any additional information you'd like to share about this project, you have the opportunity to type it in the chat. We are moving on with our agenda, and I would like to request the members in the room to feel free to pick a cup of tea, and we'll just have a short break, a tea break of 5 minutes. Let's make it a working tea break, and we'll continue with our presentation. Since we started late, let's combine the tea with our activity. So I would like to just check the chat to see if we have anything that has been shared that we should be responding to. Okay, so far we do not have any specific questions on the chat, but feel free at any point to document there. We will now move on to another presentation that gives us numeric data. We've talked about the processes, we've talked about the qualitative side, but now we need to share some numbers. And I would like to invite Mr. Lawrence Sechimpi to take us through the presentation of our performance in HIV testing services. And we know this is the entry point. As a country, we are not yet there. We still have a big big proportion of our subpopulation in men and children who are still missing out on HIV testing services. And that's one of the gaps that this project is designed to address, to contribute to. So without further ado, allow me to invite Mr. Lawrence Sechimpi under the Strategic Information Division to take us through presentation of HIV testing performance. Ladies and gentlemen, Lawrence Sechimpi.
Thank you, Dr. Patrick. Good morning once again. Allow me to give you some of the outputs from our HIV testing services under this FCI project. And I'll talk briefly how the HTS services were organized, the performance updates, challenges, and lessons. This component of HIV testing contributes to Objective 2, which seeks to do testing, linkage, and retention for men, children, and the priority populations, anticipating that at the end of the day, there will be increased demand for and access to the HTS services, including HIV self-testing. We also expected to target subpopulations, link them to care and prevention services, and increase retention in care for HIV positive individuals. Our target was to reach 22,000 eligible clients with HTS services for the duration of the project. I want to share with you the human resources from the faith structures who have supported the achievement of the results I'm going to share. As the program manager indicated, we are implementing the project in 3 regions. Masaka region, it had 6 short-term technical officers, STTAs, 6 of them. We recruited and trained and deployed 85 community carers within the Masaka region, 17 parish priests, including 1 imam, and 14 health facilities to support the linkage. Under Kampala and Wakiso region, we deployed the 6 short-term technical officers, 64 community carers who moved within the communities where they reside. We also had 16 parish priests, including some from the Orthodox churches within the Kampala-Wakiso region, and 7 health facilities where individuals were referred for confirmatory testing and other services. Within the Mubende-Luwero region, we had 6 short-term technical assistants, 46 community carers. We had to work with 17 parishes and 17 parish priests and 16 health facilities within the districts of Luwero, Nakasongola, Nakaseke. So some of the results we are going to share are attributed to these individuals' efforts. There was a delayed start. That's why you see our results start from April. I will talk about probably why. And mobilized with messages of hope. The individuals who were mobilized were 27,120. And the coverage for HTS was very low at 16%. So of the many people we mobilized, we could only give HIV self-test kits to around 4,400 to do self-testing, which translates into around 16%. And of those we gave the kits to test themselves, 95% there was evidence that they tested. The rest, we could not verify them. They took the kits, they could have changed their mind. We could have picked this information through follow-ups, but we are sure 95% tested, which is around 4,200 individuals. And 221 individuals were found to be positive, and that yield is within the expected yield in the regions. As you can see, 199 were sent to health facilities to confirm their HIV tests, which translates into 90%. So evidence we have from the health facilities accounts for only 199, which is not very bad. Our carers were sending the individuals to health facilities, those individuals who tested positive, to go and confirm, and that was the protocol. But 90% of them were confirmed HIV positive, and 54% were linked to care, around 108 individuals. As you can see, the linkage rate is suboptimal, and this called for some interest on why linkage was that low. We are quite interested in knowing how we are accessing men with these services. And as you can see from the graph, 58% of all the individuals mobilized were men. And that was within our expectation. 58% were men, and 62% of those who received HIV test kits were also men, which gives us around 1,673 individuals. 2,783. Those who reported positive, again 55% were men and 45% were women. And through confirmatory tests, there was no big difference. There was no significant difference. It was almost 50-50. But from this picture, you can see that the spirit of the project, reaching out to men, was achieved. We could not leave out women because some men were married, they had spouses, and we offered this as part of either index testing or partner testing, which was again part of our interventions under HTS, under HIV testing services. That's why you could see some women, quite many women, accessing the services. We want to understand, where do these results come from? Performance by region. As you look at these results, I want to reflect back to this slide. We deployed an army of community carers, of short-term technical assistants, of religious leaders, of faith leaders, and worked with health facilities. So when you see some regions or one region surpassing the others, you could tell probably why. We have seen Masaka region performed well. It was the leading contributor to the numbers across. When you look at the numbers mobilized, the community carers in Masaka did very great work. 43% of all the individuals we met, we accessed, we talked to came from Masaka, followed by Kampala Wakiso and then Luwero with the 22% contribution to the numbers mobilized. And we congratulate Masaka community carers, the faith leaders, and everybody who worked tirelessly to achieve this. In terms of accessing HIV self-test kits, Kampala region, Kampala Wakiso region performed well. 50% of the outputs are attributed to Kampala Wakiso, followed by Masaka and Luwero. We can understand why Mubende Luwero region probably trailed on this. They started rather late, later than the other two regions, and probably they had less time to implement. But as I mentioned at the start, overall, the HTS testing services did not start in October. They started later, around April. I mentioned that as part of the challenges. And then among the positives, 54%, around 120 came from Kampala, and 40% and 6% from Masaka and Luwero, respectively. Again, Luwero had the least positivity rate. So when you look at the overall achievement, I mentioned in my first slide is that our target was to reach 22,000 individuals with HIV testing services. And by the end of August, we don't have data for September yet, but by the end of August, we had achieved 20%. In other words, 20%, or 4,456 individuals have been accessed with HIV testing services out of our target of 22,000. And understandably, we had, among the challenges, a very big demand for self-testing. Conventional testing did not appeal to many men, to many clients. And they saw self-testing as an opportunity to do the testing, but we did not have enough testing kits. We are very grateful to the regional implementing partners who supplied the project with the self-test kits, but they are doing this within their allocated targets. And this necessarily created a challenge. There is a lot of mobilization, high demand, but the supply was within the targets that were given to the implementing partners and to the health facilities. We used to get test kits from the facilities, but the facilities had targets. So we reached around 16 to 20%, depending on which region. We had a challenge also with our community carers. Initially, screening for eligibility for self-testing was a problem. So there was a big storm Many people want to take self-test kits, yet the carers had to screen who is eligible to access the self-testing, or else they would go for the rest of the targeted APN and index testing through the conventional means. And we had to work with the health facilities to build the capacity of the community carers, ongoing capacity building, so that they could screen well. We are very grateful to the health facilities who supported us in that endeavor. And in some cases, the referral loop broke down. We had the referral forms, as Mr. Mohanji had indicated. Whoever is referred to the health facility was given a form with a provision for the health facility to send back to the community carer information regarding the referral, the diagnosis, the next steps, and whether the person referred had reached and served. But we found that through our support supervision, we found that some facilities were not sending this feedback to carers. So the carers missed out on understanding the completeness of their referrals. And this was a small challenge, but it was also a lesson for us. When we launched this project for the Catholic Church, it was time to transfer priests. We had trained them, and we got many transferred out to other parishes. Yet those other parishes were not part of the project. So we had to quickly see how to bridge the knowledge gap about the project for the incoming religious leaders, which was done as the project was being implemented. So through support supervision, we could engage the religious leaders, explain the project. We did not organize a training for them, and this necessarily slowed down a few activities. Out of the HIV testing services, we have learned lessons and we have opportunities we cannot ignore. Initially, we prescribed where to refer clients to. We initially worked with the PNFP, private, not-for-profit facilities. But we eventually found that we had to include public facilities in the referral network. You could find the public facility is nearer than the PNFP facility. So it was necessary for us to adjust, and that was a lesson we learned. We had to quickly meet and sell the project to the public facilities, negotiate HIV self-test kits so that clients could be adequately served. The opportunity we have now is maintaining and sustaining the enthusiasm exhibited by the religious leaders. The number of people who have accessed HIV self-tests and the offering of spaces at the churches, at the mosques, and the voluntary spirit of the religious leaders cannot be taken for granted. And this is a very big achievement of the project. We are actually engaged with discussing with the DHOs, with the district people, with the implementing partners, with all other stakeholders. We are urging these planners, these stakeholders, to always consider the religious and the faith leaders in the health planning. They are critical and important partners. We have seen the enthusiasm. We have seen them offering. We have seen them visit the communities to support clients within the communities, and they are trusted by the communities. So this opportunity for future programming is very, very important for us. But one of the, as we were conducting HIV testing services, we learned one lesson. Adaptation. The mobilization did not take one standard method or route. When you interact with some catechists within the Catholic Church, they preferred individual sensitization and mobilization. As we worked with the Muslim communities, they penetrated through the Juma prayers on Friday as their point of entry. But when we went to Luwero, for example, they said if we want to meet men, let us target the cattle markets and the circles, the cooperative societies. Men rarely delegate money issues. So you would find them in the cattle markets and you would find them in the circles, in their cooperative societies. And this supported us, supported our teams on mobilizing for HIV testing services. Really, these lessons we have learned, and we want to see how to continue implementing the Faith and the Community Initiative project in the next 3 to 4 years using such lessons. I can also mention here that, as I have shown you, the outputs did not cover the period October to date. There was some delayed start of the activities. We are creating partnerships. We are fine-tuning the design and the work plans and engaging the rest of the sub-grantees. So effectively, services for HTS started around April. But we are happy with the results. We just have to keep the momentum in the next years, working with the rest of the partners. I thank you for listening to me. Good morning.
A bigger round of applause for Mr. Lawrence Sechimpi. Thank you, Lawrence, for making that presentation on our performance in HIV testing services, which are the entry point along the cascade for HIV care and treatment and prevention as well. I would like to recognize in a special way the arrival of our program officer from the Centers for Disease Control and Prevention, Mr. Arthur Fitzgerald. You're most welcome. Yes, ladies and gentlemen, thank you. I recognize the community we have attending via Zoom. Please stay on board, and any questions you have, any comments, clarifications, or additions should be shared in the chat. I want to just read a few comments that we're getting via Zoom, and this is from one of the short-term technical advisors, Aiden. I request that you strongly address the government structure's active involvement in this project, because some seem reluctant and unbothered about it, especially during referrals and linkages. We need more support from the government structures. It's really needed. So thank you, Aiden, for that comment. It is taken note of. And you've seen that through these presentations, we are working with the existing structures. We are working with all partners at different levels. So we've taken note of that. And another comment came in from Musime Tadeo from St. Francis Chijaguzo Health Center. More efforts are needed, especially in equipping our facilities with self-test kits. Most of our facilities were not availed these kits, and hence hindering our much involvement in the project. And the issue of self-test kits has been highlighted also in Lawrence's presentation in HIV testing. That's one of the big challenges that we've been facing with the supply of self-test kits, and we are glad that these voices are being heard. There are more comments on the chat. Apart from starting late, this is from Lawrence Tamale in Kasana-Luwero Diocese. Apart from starting late in Kasana-Luwero Diocese, lack of self-testing kits has been a challenge. That's already highlighted. Then we've also had one of the challenges as linkage, referral, and there's a suggestion here from Aiden. I think if possible, we need to identify some focal personnel at health facilities and keep motivating them. This will probably improve health facility linkage and referral efficiency. We're taking note of this. Rachel has a comment. Good morning. My request is to put protective gadgets, in brackets, condoms, to public toilets. Such protective gadgets, that's the term they use, such that, with a disclaimer, of course, we know that as the Catholic Church, we have our doctrinal observations with regard to this, and we also are cognizant of the other faiths in which this also has its non-restrictions, if I may say. But the suggestion by Rachel is that we put these in public toilets such that people in communities can easily access them. Some find it hard to visit health facilities, requesting for condoms, and end up infecting others. And from such facilities, it is hard to access such services. Okay, then we have some more comments regarding Luwero Diocese. We started late, but the point focal person at the facility identified should be considered for smooth running of the project. So thank you for these comments. We have taken note of these comments and would like now at this point to listen to one of the experiences, if I may call it, under HIV testing. You know, specifically for the Faith Community Initiative, we're trying to reach the under-tested subpopulations, men, children, and we want to see what the experience has been of one of the community carers finding men through the Men's Guild. And at this juncture, allow me to welcome Mr. Megade Paul from Kabuoko Parish to take us through a testimony of his experience as a community carer in finding men through the Men's Guild. Ladies and gentlemen, Mr. Megade Paul.
Greetings to you all. Since the microphone has been sanitized, I beg that I remove the mask and remain with my identifier instead. That's the cap and the t-shirt that was provided as some of the things I will tell you about and how they have helped us in doing the work. I'm Megade Paul Richard, the leader of the Men's Guild in Kabuoko Parish, And in my introduction, I would like to share with you a brief story that I'm from a family far in Sanje parish, though my residence is in Kaboko. But in my family, we have lost two, a sister and brother. And my elder sister died of AIDS in my hands when I was still a student at A level. And when I joined Mubende University, Mubende National Teachers College, I left her to manage my home where I was. And for a year, she was there and taken care of. Tasso was there, but no ARVs by that time, during 1992. And she was moved back home in my absence. And later on, 1994, she died. But fortunately, God told me that I should go back home for a little while. And at night, I arrived, just told me one thing: have you come? And she died. She was suffering from AIDS, Mary Namigad. And another elder brother, Charles Kalole, also died, followed suit. And my paternal family, my paternal uncle's children, I think they were 9, but there is only one, our sister, who is remaining in Ikoshi, and the rest died of AIDS. And now the grandchildren are managing the home. So I thank UCMB for bringing me on board as I share this passion and see how I can contribute and prevent more on getting AIDS. That's the brief of my introduction. As I told you, I'm the leader of the Men's Guild in Kaboko Parish, and I've just been elected. So the structure is within the domain of the Catholic arrangement, and it is mandated to mobilize men for spiritual purposes and economic purposes as well through the church structure. So I'm not well acquainted. I'm still learning how to go about it. But the first thing in this program, that I got an activity of what to do in men under this responsibility. So it is a reciprocal. As I'm doing work with UCMB in HIV/AIDS mobilization, I'm also doing some work that I'm active leader in building the Men's Guild. And it has been all along neglected in the church affairs, and we are reviving it. The parish has 17 sub-parishes, and it also has structures at those levels. So I remain as a lead of laity in one of the sub-parishes I come from, and at the deanery, I'm the secretary. So all those are areas where I come to share the information and take up the responsibilities of doing the work as a community carer. As we are brought on board, we have done the following. In fact, after the training, we have prepared the Parish Men's Day. I think it was there in May 9th. And I'm happy to report that UCMB participated fully, assisted us, and we had an activity much from the spiritual point of view. We had other activities like the HIV/AIDS testing at the center after Mass, and also with the partnership with the DHO and the district medical team, we had an opportunity of COVID-19 testing for the first round. So now it became an interrelated activity. The spiritual arrangement we mobilized, and now with HIV testing, and then with COVID. And it is remarkable in the parish. And I would think when we call them back for another activity, they will respond. We have had multilateral approaches. I shared with UCMB, I think specifically Mr. Muhanji, the story of my friend in a village who had succumbed to a certain disease, which I could not know much, but out of my ignorance, he was taken to a shrine, a traditional shrine, for almost 3 months. He had a swollen thumb and thigh. And in fact, I did everything possible to make him agree with the family, which was not a simple battle, to take him to Masaka Referral Hospital. One of the presenters was talking about the public facilities. I think it is vital because the conditions could not warrant taking him to the St. Charles Ruanga, the health center of the parish. So we could take him to the referral hospital. The testing was done. He was negative at the referral hospital. But again, the family had been convinced that there might be some other issues, maybe witchcraft and so on. He was removed and he went back home and died. So that was also an activity. And in such, from the village and the sub-parishes, some people have come to share knowledge, what transpired with Bosco Senyonjo, who died, what went on, how did you handle this? And we have shared the information, and some have ended up testing. And we have the self-testing kits have done a lot, and good enough, I have not checked anybody or tested anybody who is negative. So I think I have around 47 cases, and they are positive. They are negative, sorry. At masses, before the lockdown, at services, the funerals, the weddings, we could share messages. Because, especially in my area, where I'm the head of the laity in the sub-parish, I could give a message of condolence, accompanied by that of encouraging people to self-test. The materials provided. As you see me, and it was not unintentional, I made it an intention to verse this way. So the community could identify. Now we see you as the leader of the men's guild, with ties, with coats, with all kind of putting on. But now, as we are provided with this, people are questioning, what's that? I have a certain linkage with the politics. Others were calling me, have you gone to FDC? No, I said no, this is not FDC, it is FCI. And what is that? Then I could explain. And from there, I could give the self-testing kits. The bag could help me carry everything that I could. The notebook, the Oral Quick, the sanitizers that were provided, and the masks. So I'm well protected, and that is a very good achievement. On the point of the multilateral approach we used, there is also a positive story I want to share with you. We had a target of the choir members, and there is a community carer as a choir master. And now we are looking how can we protect, how can we prevent HIV/AIDS other than testing, but through fidelity. And as a leader of the men's guild, I could come in to encourage men to have matrimonial arrangements. And for the good, I have 2 choir members, a lady choir member and a male choir member who are now on, are they announcements? What are they? In the church. And on the 27th November, they are taking their own vows. So we are encouraging fidelity in such arrangements through the men's guild arrangement, now the church choir, and we see how they can keep their vows without going out of the area. And now, how did I do it? I have some potential members of the church who belong to the men's guild whom I know of their potentials. They could be looking for money, how to make a wedding, all that. I got one of the members and a friend, and asked him, this is a challenge. Why don't you assist these people? He said, no, I'm giving them 1 million to start off. I think they can do such a wonderful thing, and they start. And now they started from there. And from this arrangement, I thank Mr. John Baptist Chimbugwe of Chamula, sub-parish in Kaboko Parish for the same. And now, what are the challenges we have experienced? The COVID-19 lockdown. In fact, we haven't done much during that period. When we had started, and now the lockdown came in. 2, the poor perception of the importance of the men's guild in the church. I may not mention that very few of us have appreciated this structure in the arrangement of the church. And now we are building the same. From the village, to the sub-parish, to the parish level. The main vibrant is at the dietitian level. So now we are taking up that challenge that if we can have that structure strengthened, we can do much. The men's unwillingness to test. I was chatting with one of the men. He told me, no, my wife told me she's positive. So why should I now test? I told him, this is not a representative task of testing. That you are represented by your wife. So the main thing that their partners can do it for them, for them. So it is also a challenge. Our plan. We had a plan with the Father Chaplain, Father Leonard Rutuama, and approved by the parish priest that we should have masses in the 17 sub-parishes as we rebuild the structures, so that for the purpose of the church and as well of passing these messages through a well-established structure, which is lacking at the lower levels. And now it came that the lockdown now has been released a little bit. I think we shall come back to it. The gratitude and thanks, I'd like to thank very much the UCMB for bringing me on board and giving us the opportunity on behalf of others remaining there to share this task, to have a courage of caring, of passion, of sharing, and so on. In relation to the first story I told you, what can I do to the rest of these if the others went? When I could do nothing. When I'm here and UCMB is here, then I think I'm fulfilling God's passion. Thank you very much for listening.
Thank you so much, Mr. Migade Paul from Kavuoko Parish, for sharing your testimony and your experience in finding men and getting them tested through the Men's Guild. And we want to commend you for the efforts. The struggle continues. We are not yet there. I am aware that as a country, on the first 90, we're about 84%. So it is the missing men who will get us to our UNAIDS targets and our national targets for testing. So, ladies and gentlemen, we have a few comments on the chat, and allow me to read them out. Just following the presentation by Mr. Migade Paul, who is a community carer, we have a comment from Lawrence Tamale. He says, the number of community carers in some parishes is very small. In some instances, you find that only 2 community carers work within a parish of 17 sub-parishes. I think the number of community carers should be increased to smoothen project activities. Thank you. We've taken note of that. There's another comment from Bastagaine Alex from St. Nicholas Orthodox Cathedral, Namungona. He asks, how are you planning ahead to work with schools when they fully reopen next year? Speculated by President Museveni, how is FCI going to work with schools? I believe many schools belong to religious institutions. So we will get a comment on this, how we are planning to reach out to the education structures, because all these are under, and a number of schools belong to faith institutions. So they are part of the faith structures that we can leverage in the community. There is another comment from Dr. Peter Chiravira in Zambia Hospital. We've registered a rapid surge in community HIV self-test kit distribution by Zambia Hospital since the relaxation of the June lockdown. We've captured 6 positive adolescent girls and young women this month so far who are hard for us to reach previously. Thank you, Faith Community Initiative. So it is working. And you know what the Bible says, that even one lost sheep returning to the flock is worth celebrating for. So we are grateful that these self-testing kits are giving people the opportunity to test at their convenience, and through that we shall find the missing persons living with HIV in the grassroots communities. Mr. Migade had made an error. He mentioned that some number of the people he's testing through self-testing are coming back negative, which also reflects at the success of the prevention program. So it's all tied together, and we are grateful for this. Thank you for these comments. We also have another comment from Sentema Edward. As we deal with HIV/AIDS clients, there are TB patients being identified in the community that need to be brought on the program as our new target population. Thank you for that. So TB integration is also something that we should take note of under this. We don't want any missed opportunities. And with that, I'd like us to keep the questions coming, comments on the chat. And we're now going to move into another segment of our program. We've been dealing with the HIV testing segment. These segments are structured along the objectives of the project. So we've been dealing with the one of testing, reaching, and linking men. So we want to switch gears into another segment of gender-based violence, addressing violence against children, justice for children. And at this juncture, allow me to welcome Counsel Fred Semwanga, who is going to take us through a short presentation on violence against children, gender-based violence, issues, methods, and performance. As you're aware, the FCI project has been working closely with the Catholic Center for Legal Aid Services, and we are partnering with the legal fraternity to bring justice to the victims of GBV, the victims of VAC, and also in the same breath, prevent these unjust actions that are still driving the epidemic within our communities. So ladies and gentlemen, I would like us to welcome Council Fred Semwanga. You're welcome.
Thank you, moderator. I observe the protocol. Lawrence, do I have my slide? My name is Frederick Semwanga. I also work for Uganda Episcopal Conference in the Department of Justice and Peace. We have been supporting the project to implement activities related to addressing gender-based violence and reducing violence against children. The Justice and Peace Department of the Uganda Episcopal Conference is working closely with the Catholic Lawyers Fraternity under their legal aid arm, which is the Catholic Center for Legal Aid Services, to address that component. The issues we mainly covered, or we cover under this project, are related to domestic violence, gender-based violence, violence of inheritance rights, especially for HIV and AIDS-related orphans, violation of widows' rights to property, and forced marriages for women who lost their spouses due to HIV and AIDS. We have been looking at cases of child neglect leading to high levels of abuse in different forms. The most predominant ones which have been reported to us related to the risk of HIV and AIDS related to rape and many cases of defilement, especially at the community level. We have received cases of child labor, which again expose children to contracting HIV and AIDS. And the other pertinent issue which has been prevalent during the project period is the continuing violation of the right to education due to the COVID-19 pandemic. This has had a number of related violations which are still continuing. Actually, all the previous issues I've noted have been escalated by the period of COVID-19. Therefore, the Catholic Center for Legal Aid Services, together with the Justice and Peace Department, have worked closely with the UCMB created community carers to reach out to the communities. And we have had a number of interventions which will form our methodology, that we targeted formation of child protection committees. And these child protection committees have been our entry points to communities. When we went to the communities, we found that there were committees which had been earlier created by government, but non-operational. So we were able to start a number of committees in the parishes where we're able to reach. In the Catholic parishes, where we're able to reach. So we're able to have committees in Kampala, Chinda-Mitiana, Kasana-Luwero diocese. So for this period, we have been able to have those established and trained. Then we also targeted to engage government institutions like the Ministry of Labor, the local governments on issues of policy relating to children. And here we have also been able to engage the local governments, again, on issues, bylaws, policies relating to child protection as key contact places where the community carers, where the child protection committees, where the security agencies are able to report cases of violence against children. We also had a mandate of empowering the interreligious forums. Since the project reaches out to the three faith groups, we conducted TOTs for selected religious, interreligious leaders on the basic knowledge, practices, and laws related to child protection. And because of the interaction with these groups, that is when we have been able, actually towards the end, we have been overwhelmed with a number of cases of violence related to children because of the earlier capacity building initiatives, because of the trainings which we undertook. We also conducted trainings for the frontline medical workers from Kampala and Kasana-Luwero still on policies and laws relating to child protection and violence against children. Why frontline medical workers? Because they are also the very, very contact persons where the cases of violence, they are reported to the medical workers as these victims go to the various health facilities to receive medical attention. And together with UCMB, we conceptualized messages, IEC messages, relating to child protection and violence against children. Maybe this can be the best example. You can turn in the camera. Yes, turn your back in the camera to see that message behind you. No, the gentleman here. Yes. So that is one of the messages which we have conceptualized together with the UCMB. These are advocacy messages which are going out to the communities in a bid to prevent violence against children that is linked to the spread of HIV/AIDS. So here we have the t-shirts, we have the capes, we have the bags. These are continuous advocacy messages that we conceptualize together with UCMB. Thank you. We shall move very fast. I've talked about that. We also conducted 2 radio programs, still on violence against children. And within the radio programs, we have had the continuing sport messages, or with messages, with information relating and discouraging violence against children and gender-based violence. We developed an abridged handbook on laws and policies relating to children. That is the handbook. It is a compilation of all the laws of Uganda, and it is a summary, it is simplified, the laws of Uganda, and some provisions of international instruments relating to violence against children, and more specific laws related to the rights of people people affected and people infected with HIV and AIDS. That is a compilation. Then, as an advocacy tool, we compiled the pertinent issues relating to violence against children, especially during the COVID-19 era. So this has formed our advocacy engagements with members of the religious institutions, with local governments, and with the central government. So those are the two publications we have come up with during this period. Again, together with UCMB, we conducted training of the community carers. As I said, the community carers were created by the structure of UCMB. They are in the community. They link up with the STTAs, then the STTAs link with us on various matters. So we conducted trainings in Masaka for the selected parishes of the community carers. Again, on the skills, how do you monitor cases of violence against children? How do you identify? How do you report the cases of violence against children? And again, because of this, we're able to start receiving reports reported to us of cases of violence against children. Where possible, we have made interventions, and others are still ongoing. Then, related to the above, we are continuing to follow up and to make interventions on the reported cases of violence against children. And we can say that during this period, at least we have recorded 35 cases of abuse from either the medical facilities, from the STTAs, from the community carers, and from the religious institutions, and also from the child protection committees we formed. So these categories of groups I've talked about form a basis through which we can receive these cases of violence against children reported to us for further action. Challenges. There is high-level ignorance of the laws and policies relating to protection of children, especially the policies, the rights of children affected and infected with HIV and AIDS. This one cuts across, even within religious institutions, even in the community, even among government institutions. Then the other challenge is that there are many cases that are coming up now, which require urgent attention with limited resources. The cases cases of violence against children, sometimes you cannot envisage which case is coming. You cannot know who is going to abuse a child tomorrow. So we always talk about emerging cases, the emerging cases. The other day, a catechist called us from Masaka, that there is a case of rape in Masaka, where we needed to make that intervention. There was an STTA from Kakiri who also called us. It was on Sunday that there's this case here. The perpetrator is apprehended, but they need facilitation to be taken to court. So we have a problem with the justice system that is not properly facilitated. And at the end of the day, once the justice system is not facilitated, it impacts on the victim. Even where the police would wish to make an intervention, they'll say, we don't have fuel in our car. We don't have facilitation to go and undertake investigations. So this compromises access to justice for victims of abuse, especially children and women. Then the other challenge is limited access to technology, Again, when you look at cases of violence at the community level, you'll also find that even amongst the community carers, the access to modern technology, which would have made reporting of cases very, very easy, is still limited. So we shall need capacity building for the community carers and other contact personnel at the local level into modern technology for them to be able to report and respond to the violence against children very fast. Then the other challenge is that the Justice and Peace Department and the Catholic Center for Legal Aid Services handles this component alone. That means we serve all the project areas, which has been stretching. So we believe that once we expand, we shall be able to reach out to all the project areas. For the previous period, we have worked in Kampala, a few activities in Masaka, Luwero, and Chinamitiana, but addressing and working with all the three religious institutions. Lessons learned during this period: strengthening the local structures. The local structures, I mean the religious structures, are very, very, very good entry points into achieving what you want, because they are within the community. They are in touch with the local dynamics of the community. So that has been a very, very good lesson to us, because it is through these local structures that we are able to identify the cases of violation of the rights of children and gender-based violence. Then the other lesson learned is working with medical facilities. The medical facilities are also very, very, very good contact points for us to get the cases. As I earlier submitted, that the medical facilities are contact points. If it is a case of rape, if it is a case of defilement, even after reaching police, they always tell them to go and get a medical report. So we see them as very, very good contact points for us to be able to address this. Then working with security agencies is also critical to achieving justice for children who are victims of violence. As I said, however much you have a very strong religious structure, you have the medical facilities reported, but when you have a rotten security system, then we shall not be able to access justice for children. So we are seeing to it that we work with the three institutions together to ensure that there is constructive, continuous access to justice for children. This is my brief presentation. I thank you very much.
Ladies and gentlemen, another round of applause for Councillor Frederick Semwanga. Yes, thank you, Council, and thank you for this presentation. You may take your seat, and any questions that we get on the chat, or anyone who raises their hand and has a question, we'll give you the opportunity to ask. We already have a question from Dr. Mzamir from Uganda Muslim Medical Bureau. Please unmute and air your question.
Okay, thank you, Mr. Semwanga, Councillor Semwanga. Thank you for the presentation. I've loved everything that you presented. My only question is, when are you bringing the UCMB structures on board in terms of those trainings and the other capacity building opportunities, especially to our lower structures, like the county sheikhs and the implementers, the emirats and their imams? Thank you very much.
Okay.
I respond?
Yes, you may. Please go ahead.
In the sub next year. We shall come next year. Yes,
Messages of hope.
Someone is telling it is next week.
Next week. Next.
It is Friday.
Next year is next week, in 2 days' time. So thank you for that. Any more questions? We take note of the fact that gender-based violence and violence against children are drivers of the epidemic, and addressing them is key to epidemic control. We've just been in lockdowns, and this COVID-19 has also had its contribution to violence. Dr. Sam, kindly unmute and share something with us. Thank you.
I thought I'd switched it. Okay.
Okay.
I just want to respond a little bit to Mr. Mzamil's question. Definitely, we would want really to go there. When you talk of next year, means really from October. But earlier on, we also mentioned some of the current new arrangements. And I think my comment would be that it's one of the reasons we would really find it useful for us to continue working with these health facilities under the Muslim Medical Bureau and Orthodox Medical Bureau. I mentioned at the beginning that this project was like a design and build. We designed it and built it. So really the design is with us. It is not with any other IP. So, and then the unique relationship that we have, I think also made it very more easy for us to do a number of things besides what has just been presented. So it is really a case for our continuity to work with them if the arrangement is allowed. And I think we can get an insight more into that, probably not today, but as we continue discussing. Yeah, thank you. But in general, I just wanted to, I think what we're going to do is that we'll, we have seen lessons learned coming with each of these presentations. And I think for us as UCMB, we will have a section where we will put all the lessons that we have learned from this project instead of segregating them under the different sections. Thank you.
Thank you, Dr. Sam, for that assurance. And Muslim Medical Bureau, we are together in this, as you've heard. And I'd like to just thank you for that. We are continuing still. If anyone on the chat has any question or clarification directed to council or to any of the previous presenters, please feel free. We have a comment or a question. Actually, this is regarding the HIV self-testing. Dr. Alamo Stella says it would be good to know who of those who test positive are first-time testers as part of the cascade. And request Lawrence to just make a comment on this as we're getting this testing data to find out those who are first-time testers. Mr. Sechimpi, can you just, okay. I think we've taken note of this, and in our subsequent data sharing, we will make efforts to disaggregate them by first-time versus repeat testers. We also have a comment from somebody who didn't rename themselves, Galaxy M1. In the long run, the project should think of providing transport like bicycles to carers to enable them reach long areas from where they reside. We've taken note of this, bicycles, to ease the operations of community carers and facilitators at community level. We have someone on the call, Kambabazi Susan, who has a question in Luganda, and I would like to give her the opportunity to share her question. Nyabo osobola kubuuza ekibuuzo kyo. You'll forgive my Luganda, I'm trying. Nyabo bw'oba olina ekibuuzo mu Luganda osobola okukibuuza kati tujja kuddamu. If you're with her, please kindly enable her to unmute and to share her question. Or it could be typed in the chat. Kambabazi Susan, Jolie. Okay, as we wait for her to hear from her, we will move on to another testimony under the segment of justice, violence against children, and addressing GBV and VAC. We have a testimony from a carer on GBV management, and she's a catechist from Lamagwa Parish. She's going to tell us her experience with regard to GBV management, and I think these grassroots stories, they give us, this is just a sample of what actually is happening in the community. Ladies and gentlemen, welcome with me, Mrs. Donanta from Luamagwa Parish. She will speak in Luganda, and I'll request Mr. Muhanji Justus to translate into English. Nyavo, over to you.
Nsanyusa nnyo okubeera wano. Nsanyusa nnyo okubeera wano mu konferensi eno. Amanya gange bampita musomesa Donanta okuva e Lwamagwa Parish. Omulimu gwange nkulira abasomesa 8 abatwala ebisomesa 8. Ate ku lukiiko lwa Parish Executive nkola ng'omuwanika. Era neebaza nesekwebaza yenna bwana mukulu waffe Reverend Father Vincent Nakana eyasobola okutulondamu abasomesa 5. Nyongera n'okwebaza ekitongole ekya Uganda Catholic Medical Bureau eyasaawo entegeka ez'okuwangula abakulembeze ab'enzikiriza z'amadiini. Okutusomesa ebikwatagana n'ebyobulamu, kubanga ebiseera biri twali tuyigiriza ekigambo kya Katonda ne tukomaawo, naye kati okuva lwe baatutwala ne batutendeka ate kati kyanjawulo nnyo, kubanga bwe tuba tuyigiriza tuteekamu n'ebyobulamu abantu ne tubamatiza n'ebikwatagana n'obutabanguko mu maka. Era kati ennaku zino kyanjawulo, abantu batweyambisa nnyo singa wabaawo amaka agasowaganye. Tuli batendeke bulungi ate ensonga tuzikwata mu bugenderevu. Ebiseera ebisinga abamu bwe banga nga basowaganye akutuukirira olumu n'omuwa referral form n'omudirecting agende ewa CDO oba ku poliisi. Ensonga ezo ne buluusi ne batamulamula bulungi. Oluganda avuddewo ayogedde keesi yali eva mu kitundu gye mbeera. Abantu abo baali balina obutakkaanya ate ng'omusajja amunywa amwenge. Nagezaako okulufaalinga ensonga ezo ne batafuna okuyambibwa. Era ekyaddirira omukyala bwe yakomawo ekiro n'addukira wa Nazaara, naye omwami yamulumbayo. Kati n'omukyala naye okwetaasa yakuba omusajja omutwe n'agwasa. Kati ku makya CDO yali amugamba amukeere omukyala. Kati omwami n'agenda ng'omuzaayi gutiiriika ku poliisi. Baasookera wa rizaavu eyali awo ku kitundu kyaffe. ne bamugamba kakati bonna ne batuukirawo wamu ne bamugamba ono alina olubale ate gwe tolina lubale kakati gwonawaabira atya olubale ng'ate gwe wamukubye ne bagamba mugende mwefiire. Kati lwali lwa Sande bwe nava ku Sande nengendayo ndaba omukyala wajakomye bamuyambye batu bamuyambye kati omukyala bwe yakomawo nga bamaze obagoba n'atya ogenda ewaka namusanga ali mu lusuku kati nemugamba nemubuuza omwami mwali naŋŋamba ye ngamba jangu tugende nasanga omwami nga yeebase omukyala ali mu lusuku mugjeeyo nembatuuza bombi nembawa kansolingi omwami nemulaga obubi obuli mu katabanko ke yakoze ate nemulaga n'ekirungi kyajja okusingaana singa amaka ge gabeeramu emirembe. Ninyongera okumukakasa nemugamba nze nali chairperson wa FCI okumala ebisanja nga biwera. Yali amanye engeri gye nkwatamu ebintu byange. Nyamugamba kakkana nkutaase bwe kibanga seekyo bajja kusiba. Omwami yampuliriza n'aŋŋamba musomesa nkwegayiridde tonsiba nti bw'okola bye njagala sijja kusiba naye bw'obeerezaamu okukyankalanya amaka go ojja kusibibwa. N'agamba ndayidde nemugaa kiki ekinkakasa nti tojja kuddamu. Nagaa kyonna kyoyagala nkole nja kikola. Kyenakola namukozesa obuwandiike n'asayininga era okuva olwo omusajja yaleka obutabanguko mu maka ge kati weebali balina emirembe. Emirimu gino tugikola tutya? Ebiseera ebisinga ffe bakatekisiti tubeera mu bantu mu mikolo emirungi egy'essanyu wamu n'egy'ennaku mu kuziika nga mu kufiirwa. Bwe tuba tuyigiriza tuyingizaamu ebikwataganye n'obutabanguko ate ne twongera okumatiza abantu okwekebeza bamanye obulamu bwabwe nga bwe buyimiridde era abantu bakipiikinze nnyo ne bakyagala. Bwe mwatuweereza t-shirt n'enkofiira wamu ne taagizi n'ebbaaga nga ziriko ebigambo ebikwatagana, bwe mba mbyambadde wempita buli omu agamba musomesa bino wabijja wa okola mulimo ki nga munnyonnyola. Kati weewuunye beereeta bokka ne bansanga ewaka nemukansolinga bw'aba ayagala kumukebera nemukebera. Bwe musanga ali HIV positive mu directinga ku St. Jacob ate naafuna okuyambibwa era n'abamu eddagala baalitandise era bamira bulungi. Abavubuka bwe tuba abavubuka bw'oba bakutte empola bakuwuliriza ate n'obajjamu kyoyagala. Abamu ntera basanga ku garaji zaabwe nenyumyamu nabo, abalala ku boda era omu namuzuula nga kituufu ng'ali positive ne mu directinga ku St. Jacob ne bamuggyako omusaayi era ne basanga nga kituufu ali positive. Yasooka okutya okumira eddagala n'agamba musomesa ekizibu omukyala yali negative ng'omwami ali positive. N'agamba mukyala wange bw'amanya ekituufu ajja kuntolokako n'eddagala sina wenditeeka ate sina wenditereka abatasobola kubyogera. Omusajja yasooka kunzitowerera naye nenkubirako Mr. Mwangi nkwebaza kubanga bwe tufuna okuzitowereddwa tukubira ate n'otuwa obuwabuzi ate n'otuyamba. Omwami we bwe yayogera naye bwe naddamu omusinkana n'akkiriza ne tugenda n'afuna eddagala nenfuna wendimuteera kati amira bulungi. Ekirala bwe tuba tugenda kuwandiika abagole abogattibwa abo bo osooka n'obasomesa eby'omwoyo ate n'oyingizaamu n'ebyobulamu ate bonna ne bakkiriza okwekebeza nga bali bombi kubanga ekintu kye bagendamu kya lubeerera mpaka kufa. Kati basanyufu kubanga tuli tubadde tubawandiika nga tubadirectinga bwana mukulu waffe ng'abawandiika nga tutandika obbayigiriza. Naye kati bw'aba amanyi nti omuntu gw'agenda kugattibwa naye mulamu bulungi kibawa essanyu ate ne kibongera n'okwekuuma. Kati ebikwataganye n'okufuna abantu mu butuufu bwabyo tugezaako okulambula mu COVID muno babadde batugaana okukunga abantu naye tubadde tugezaako okutambula nju ku nju ng'osangamu omwami n'omukyala era ng'obasomesa ng'obalaga obulungi obuli mu kwekebeza n'obalaga n'obulungi obubeera mu maka gaabwe ate n'obalaga n'ebibi ebiri mu ekyo obuteekebeza ate n'obutabanguko bwe bubeera mu maka ebibi biki bye bireeta ne bakyaniriza kubanga abasinga batya ogenda ku ddwaliro nja kusangayo gundi ajja kundaba era kyekimu n'abavubuka kati omuvubuka bw'omusingaana nga muli babiri agamba eki kirungi kubanga teri agenda okumanya ne bw'omusanga nga mulwadde omulifaalinga yekka n'agenda ku ddwaliro n'afuna kyayagala nga teri amanyi era bakyagadde bajumbidde. Era n'ebiseera ebisinga amaka agasoowaganye kati batandise okutweyambisa nnyo ne bakyamaani bwe babeera n'ensonga ezibakaluubiridde kyamaani wange atera kumpita mu nsonga ezo ez'amaka era nemba kansolinga nembawa obuwabuzi ate amaka ne gaddamu ne gatereera kubanga eminyeeta ensangi zino mu masinzizo bo babeerayo abamu abo bolanga mu masinzizo tabeerayo bw'oba oyisayiseemu n'omusanga awo ku garagi oba bali ku puulu zaabwe oba bali ku matatu bw'oyisamu enjiriyo ate abamu ne bawuliriza n'osanga nga bakugoberedde n'akusangira ddala ewaka ewuwo n'omukolako era n'asigala nga mumativu. Era neebaliza ddala obukugu bwe mutuwadde ate n'obumanyirivu bwe mututaddemu nyongera n'okubeebaza n'obuyambi bwonna bwe mutuwa butusindise kinene okukola omulimu guno era newe tubeera tukola omulimu nga twagadde era tuba tugwagala mpozi mu biseera eby'enkuba kuno kusomoozebwa okulimu mu biseera eby'enkuba awo tuba twetaagayo nga kaminfuuli oba ne gamubutusi bwe kiba kisobose sobole okukola obulungi omulimu guno era neebaza ne bakulu baffe nga Ssentema Edward ne Mangi abo bentera okukubira buli kadde ndowooza bwe mbawa obubaka ekyo kindaze nti babutuusa gye muli kwe kumpita nnyongere okutegeera kyekigenda mu maaso. Neyanziza neyanzeege mwebale nnyo okumpuliriza Mukama bampeera omukisa.
Mwebale nnyo nnyabo tweyanzeege. I'll request Justus to summarize what she has just shared with us in English for the benefit of everyone. Thank you.
Okay. Thank you, Dr. Patrick. The lady who has just spoken to us is by the names of Donanta Tukundane. She's a catechist in Ruamagwa Parish, which is located in Rakai district. She said she's in charge of 8 sub-parishes under her jurisdiction, and she supervises faith work or faith-related activities in that area. Her story is related to how, after acquiring skills on how to manage and how to intervene in gender-based violence and violence against children situations, she has worked with the community to cause a change. And she has cited a number of cases, but the one that she emphasized was where there was a particular case of a man and his wife were fighting. The woman left the home and went back to her parents, but the husband followed her there, and they had a very bad fight. And the lady, in response, injured her husband on the head. The husband decided to run for help to police, and the lady followed her. When they reached, they were referred to the community development officer, who is a government agent. Unfortunately, when they reached the government agent, they were not assisted. They were instead told to go and solve their issues at home. Along the way, Donanta was made aware of this case, and she chose to intervene. When she reached their home, she found the lady had been hiding in the banana plantation, fearing fighting again with the husband. So she convinced her out and went and met the husband at home, counseled them, made the husband calm down, and resolved the matter amicably. To emphasize that such a situation would not arise, she made the husband sign a commitment letter that he will not cause any violence against his wife anymore. And she has said she shared the signed commitment letter with us. She has also highlighted the importance of the IEC materials that have been given to the community carers, especially the t-shirts and the capes and the bags, which also bear messages of hope and messages against violence, messages touching GBV and violence against children, that help them not only in passing on the message, but also in helping them being identified easily, so that the community can come to them for support and for help. Donanta has also highlighted how she uses various opportunities to mobilize and to reach people who need services, particularly targeting the youth in garages, border stages, and pool table places, because those are the places that usually attract the youth. So she has highlighted how she goes to those places to interact with the youth. First, to educate them about HIV testing, about gender-based violence, and she has got a number of youth and adolescents access services through that. Then she has also highlighted using the avenues in the church, especially the marriage counseling sessions, home visits, and because of her good work, she has highlighted that nowadays even the local leaders, especially the chairman LC ones, invite her to support them in resolving conflicts in families and GBV cases at community level. She has thanked UCMB and the partners for the support, and has asked for these interventions to continue because they have really helped the community. That's the summary of what she has presented. I thank you.
Thank you so much. Thank you, Mr. Muhanji, for that very well summarized and clear portrayal of the community impact that the FCI project is doing in terms of violence. We have some submissions on the group. The Sentema Edward says there is need to establish a community-based child protection system at village level to prevent and respond to abuse, exploitation, and support alternative care options for children without adequate family care. Council bribe is killing us at local level, especially with cases involving children. This is contributed to by Mr. Sentema. He's an STTA in Masaka, short-term technical advisor. Thank you for the presentation, Council. There's another experience here on child violence. We have the issue of culture where some parents are too rigid to their culture observation. What should we do to them, especially the Banyarwanda who are still following traditions of marrying off their daughters at an early age, the practice of okusitula? I think Council has taken note of this question. Then we also have a scenario Tulina, I'm going to read it as it is, and I think I'll translate it into English. Tulina omusango gwe twakolako ng'omwami omu yakuba omwana namuyisa bubi nnyo ne tumutwala ku poliisi ne bamusiba e Kakiri, naye bwe yamalayo 1 week ne bamweyimirira n'avaayo. Kati ali ku kyalo naye omwana teyafuna bwenkanya. Ffe abamuyamba omwana oyo twagala omusajja oyo bamuteeke mu kooti avunaanibwe, naye tuyambirwa tutya? So there is a case here of there is a perpetrator who violated a child, was taken to Kachiri police, and he was kept in custody for only 1 week, and then he was freed. He's on the village, walking free, and Kembabazi Susan, the team that are helping this child, are asking how can they access justice for this child. That this gentleman, I don't know if he suits the term, but that this perpetrator gets taken to court. So I'll also read something else about violence, submitted by Godfrey from Bulo Parish. Tufuna akaseera akazibu okugoberera GBV cases, cause sub-parishes ziri wala nnyo. We need transport airtime. He's saying it's hard to follow up some of these GBV cases because of long distances, transport, and airtime. So we've taken note of that. I'll request Council to just make comments on these submissions as we proceed. Thank you.
Number one, the one on bribes. In my presentation, we have forums where we engage the security agencies, where we engage local government structures and central government structures. And we also have lawyers that directly engage with these security agencies. The challenge is once a perpetrator realizes that there is no support system to this victim, once a security agency realizes that this is an ordinary Ugandan from the village, they'll be able to take the bribes. But this time, even where someone takes a bribe and the process of investigation has been properly undertaken, and there is a follow-up by one of our legal teams, we can be able to follow up the matter up to the conclusion. So what we can do as far as bribes are concerned is continuous follow-up even if it is an STTA, even if it is a community carer, a medical person, a religious leader, continuous follow-up is very, very, very important. Some cases lose track because of lack of follow-up. So this is one of the issues we're emphasizing. Continuous follow-up and engaging with the various stakeholders on identifying the perpetrators. Child violence related to culture. That's why we are coming up with the publications. That's why we are still emphasizing the awareness and education on the existing legal frameworks, because there is some of these people where child marriages are still taking place. They don't know that it is an offense. That's why it is important that we continue with the education, with the sensitization, to change the minds of the people as far as this is concerned. But in addition, let the community carers, let the members of the management committee report these cases to us. We shall be able to investigate and bring these people to book once they are reported to us. The case in Kakiri, we have received that case. It has been reported to us, and we are undertaking efforts to follow up on that case. We are following up on that case. Then below, I think that was a challenge on, I think, transport. They're not able to follow up on certain cases because of the distances within the communities where they do the work. I think those were the questions.
Thank you very much, Council. Just to translate for the benefit of Kambabazi, Nyabo, Council agambye nti kese ya Kakiri bagirina era bali mu kugikolako, omwana oyo bagenda muyamba okufuna what's justice again? Obwenkanya. Nyabo. Okay, thank you for that. I think this is a rich discussion. Please keep the questions coming. We have a question here from Musime Tadeo from St. Francis Chijaguzo about a situation where in HIV self-testing, and you've done couple counseling, one partner tests positive and the other tests negative. Could you share with us any challenges and experience on this? Well, this is a situation of discordant couple, a situation of HIV testing, and you end up with a discordant couple. And what I can say about this is that before testing, we usually give people the opportunity to choose whether to get tested as a couple or as individuals, but we like encouraging couple counseling because we want people to get tested together and to know together. Now, during the pre-test counseling, we have to emphasize what happens after the result. And in both cases, we should do it in a proactive way that, be it positive, this is the path that we shall take, be it negative, we shall go on the prevention arm, and to give people hope that HIV is not a death sentence. So one of the challenges that discordancy could create is violence and pointing fingers who brought the virus into the relationship, into the marriage. So we have to be mindful of this, and that's why these aspects of violence have to be integrated into HIV prevention and in HIV service delivery. So as counselors, we have counselors on the team in UCMB who help us with such cases, and we work together with the counselors at facility and community level to address. If you reach a scenario where you're stuck, please do not hesitate to contact Mediatrix. We have Christine Demaga and other members on the UCMB team who are technical in this area of both counseling and self-testing. So there is hope. FCI integrates prevention, including PrEP, and that was presented. So the discordant couple can benefit from PrEP, and they can also benefit from treatment for the partner who tests positive and prevention for the one who is negative. So I would like us to move on to another segment, and now one of the objectives of the FCI project is to create demand through the faith structures. And we would like to hear the experience from other partners. We shall begin with the Uganda Empowerment Mission, and then we shall hear from the other medical bureaus that have been working with UCMB. We shall hear from UOMB, the Orthodox Medical Bureau, and the Muslim Medical Bureau. At this juncture, I would like to invite Catherine from Uganda Empowerment Mission to share her screen and to make a presentation on behalf of UGEM. Catherine, you're welcome.
Thank you. Good afternoon, everyone. My name is Catherine Nandago, and I work for Uganda Empowerment Mission. I'll be taking you through the UGEM experiences in working with the FCI project for the faith-based leaders. I'm going to share my presentation. Actually, I'm going to share my screen, so it's what will be guiding us through the presentation. Are you able to see my screen?
Yes, we are seeing it.
Thank you. Thank you. Like it's just been introduced, we are Uganda Empowerment Mission. We are.
Can you put it into a slideshow mode? Slideshow. Yes.
Okay, thank you. Yes, Uganda Empowerment Mission is a non-government organization, and we are specialized in serving key and priority populations, basically through community mobilization and awareness creation, with a view to reduce risk and vulnerabilities among the KPPs we've just mentioned. The focus areas, we basically deal in community mobilization, in advocacy. Under advocacy, we engage in advocacy meetings, we do IEC, we engage in service delivery for key and priority populations, including HIV, integrated HIV testing, HIV prevention, and other related services. We engage in capacity building and system strengthening to ensure that we effectively reach the groups at local level. We engage in partnerships and network development. And under here, we are working with a number of civil society organizations, including faith-based facilities and networks. We engage in referrals and linkages, especially for our target groups, for HIV services and other related like mental health. We also do research and documentation. Uganda Empowerment Mission ensures that most of its interventions are evidence-based. So through the research we do, that is where we base our interventions. Now, we have done some work with the FCI project in Kampala and Wakiso. Ideally, we were supposed to go through the entire project area, but due to time limitations, we focused in Kampala and Wakiso. We engaged the faith leaders in the different sects, that is the Muslims, the Catholics, and the Orthodox. But during our engagements, we were sensitive to the religious beliefs of the different faiths as we were working. I'll straight away go to the achievements. We managed to do 10 orientation and sensitization meetings, integrating HIV, GBV, COVID among the faith-based leaders, that is the Muslims, the Catholics, including parish priests, carers, parishioners, Sabbath priests, the imams and sheikhs, and we can say we have built their capacity. We have also done integrated HIV testing services, and under there we've managed to reach 1,156 members of the vulnerable populations, particularly key and priority populations, those numbers, and we've served them with HIV counseling and testing services, integrated with other services, including SRH, GBV screening, STI screening, and treatment. And out of the there's so many tested, the 1,156, we managed to link 35 new positives to care and treatment in the different facilities that we worked with. We have also been able to reach 933 vulnerable individuals with HIV-related messages through dialogues in hotspots and congregate settings for men. We have also done APN, and to date we have followed up 10 indexes and a number of positives identified and have been linked to our facility for care and treatment services. We are also doing a success story. And once it is ready, we shall be able to share it with the stakeholders. We have also done support supervisions and data quality assessments. And in here, we have been able to provide technical support and mentoring to the service providers we worked with, including the community carers and the facilities. Now, we have also been able to learn some lessons as we were implementing. We got to learn that faith leaders have the capacity to reach out to the vulnerable populations or the target groups once they are well equipped with the community dynamics. For instance, if it is KP populations, if you oriented them very well and they know the kind of target group that they are going to meet, they are able to reach them, they can ably reach them without any issues. We have also learned that faith leaders are of great influence and they command a lot of respect, irrespective of their background. Now, being a key population serving organization, we know that even these guys, when they are talked to by these faith leaders, they listen. We have seen this happening. We have seen faith leaders mobilizing. We have seen faith leaders counseling. And these people have generally taken up the advice. They have taken up the services due to their mobilization. We have also learned that faith leaders are a great resource in service delivery. During this project, we had faith leaders doing support supervision visits. We had faith leaders monitoring, and this boosted boosted the morale of the teams that were implementing. I just wanted to share with you pictorials of what transpired as part of our experiences, what transpired. This was the parish priest. This is the parish priest of Bundeba in one of the support supervision visits in one of the hotspots out there in community. This was an engagement with the Muslim faith leaders in Buaise area. Just like we said, we are engaging the different faith-based associations. So we engage the Muslim leaders. This was the parish priest of Buaise. He was speaking to a few members from the KPP group. He had an interaction with them after visiting the outreach. And this was a carer. Just like we've told you that the project has built capacity, the carers are able to go out and work. They are doing counseling. So during one of the outreaches in the hotspot, the carer was doing counseling. So she was talking to one of the KPs down there in the hotspot. As we implemented also, I want to mention that we had a few challenges here and there. We encountered an issue of high demand for consumables, yet the supplies were very few. We also encountered a challenge of lack of tailored IEC materials. While we were doing sensitizations, the communities needed to understand more about this project, but the IEC, the targeted IEC materials were very few. So we thought that we needed more IECs. We also noticed that the implementation was very short, the time frame. Basically, around 2 months. 2 months of implementation was such a short time frame for Uganda Empowerment Mission. Nevertheless, we managed to achieve some good outputs. As UGM, we are recommending that future implementation will be equipped with more SRH consumables. We desire for a longer partnership as Uganda Empowerment Mission to create meaningful impact. But also, we are recommending that IEC materials be printed in quite large numbers to be able to reach out to the communities adequately. As I conclude, I want to appreciate the parish priests that went out, especially the parish priest of Ndeba, the parish priest of Buaise, and the parish priest of Kamocha, that went out, oversaw work, and provided guidance. Thank you so much.
Thank you so much, Uganda Empowerment Mission, represented by Catherine Nandago. And we appreciate the work that you've done in reaching the KPs, priority populations, and even engaging faith leaders, going as far as visiting the hotspots. And I think that's a new face that this intervention is bringing on board. And I would like us to continue interacting on the chat. If you have anything to ask, comment, submit with regard to what has just been presented, please feel free. We have a few comments that came in, though they were from the previous segment on justice. I will just go ahead and read them. However, this should not change our train of thinking Right now, we're also talking about demand creation. We're in the demand creation segment, but just to take us back a bit to the justice segment, some local leaders tend to suppress GBV and VAC cases. This could hinder justice to the victims. At one point, I tried to call the phone numbers that you gave us. I was not helped. This is from John Baptist Impima, the focal person from Kasanala-Wero Diocese. We regret this, but please do not give up. We want to assist, and in case the phone numbers were not able to help you get service at that point in time, please do not give up. We will address this, and we've taken note of that. Another comment is from Edith from Bulo Parish. They are just expressing their gratitude to Miss Constance for always being there for us, getting the materials in time and the motivation. And then another comment about transport, and especially during the rainy seasons, it's a challenge. Salama Abebe from Boambo Chiti Parish Orthodox Church, requesting that jackets and gumboots be part of the package given to the community carers. There is a comment from Robert Kayemba to UGM. He likes the intervention of UGM doing a data quality assurance and requests that the results from the DQA be shared. And he wants to compare with the DQA that has just been concluded. Robert works with UCMB. There's a question here, a suggestion by Sentamu Cleophas to UGM. Monsignor John Baptist Sevayiga is grateful for involving him in the project. This message has been shared by Sentamu Cleophas. It's just a comment. And we thank you for this, and thank you for this feedback that we are getting on the different presentations that are being made. Please keep them coming, and I have noticed that no one has raised their hand, so people seem to prefer to type, which is also fine. We shall move on to another presentation by a partner medical bureau, Uganda Muslim Medical Bureau, presented by Dr. Mzamir, and I'd like to invite him to come and share with us the experience from the side of UMMB. And ladies and gentlemen, please welcome with me Uganda Muslim Medical Bureau, represented by Dr. Mzamir. Thank you.
Assalamu alaikum wa rahmatullah. Presentation. Should I use my laptop? Thank you for this opportunity you've given us to present to this congregation. This is our performance for the period running January to September 2021. FCI with the UCMB has been implemented in those 5 districts Those are the local government districts that we earmarked for this as a pilot. Kampala is Kampala in the local government language, but it is Machindi in the Muslim Supreme Council district arrangement. So it was in Machindi Muslim district, then Wachiso, Butambala. Butambala is not also a Muslim structured district, but it is called Great Mpigi Muslim district. So we had it also in Masaka and Iliantonde. The support from CDC, we started off with the following. We had the imams and their assistants. The imams and their assistants refer to the committees at the mosque level. These are key in fostering most of the changes we see in the Muslim community. We have the Naibu imams, or the assistants to imams, who are most cases the youth representatives at the mosque level. We have the Amirats. The Amirats are the women leaders, whom we would call a senior woman at the mosque level. They also handle most of the women affairs at that level. So we began by identifying them, mapping them from the different districts that we had. Remember, our mapping was guided or informed by the presence of a health center that is attached to Uganda Muslim Medical Bureau. So the choosing of these mosques was within the catchment areas where we had the facilities where these clients could be referred to. What has been done, we identified 36 mosques. So each facility has a total of 6 mosques serving the catchment area. A total of 6 facilities were also identified in those counties. We have also what we call twalis. The twalis are like the Gombolola or the sub-counties in case of the local government. So we had that the twalis, in each twali we got 6 mosques where we implemented this project. The facilities were attached to these mosques and joined to work together. We trained a total of 108 imams and their assistants from those 36 mosques. We also identified what we call the FCI community supervisors. These are the people who have been key in supervising, training, and overseeing the activities of the imams and their assistants. Most of these ones are qualified medical teams who are located in those areas where these facilities are. We also identified VHTs that would be attached to these facilities to support the imams, especially when it comes to referral of HIV positive cases identified. And there are some GBV cases that required medical attention, so the VHTs and the FCI supervisors would be called upon to further some of these cases to the next level. We also engaged vigorously the UMSC structure. UMSC is Uganda Muslim Supreme Council, from the national leadership, the management, the executive. Then we went to the regional cadres. Within these 5 districts, we have 3 regions. We have East Uganda, West Uganda, Kampala. We had the district cadres also involved and oriented on most of the aspects of FCI. With these, they also empowered the county sheikhs, between abakulu b'amatwale. So these ones were also oriented and were very instrumental in identifying the active imams. We developed some tools that are being used by the community workers. One of them is that booklet you see there. It contains a lot of messages that are being used by the community leaders, especially the imams, amirats, and the naibu imams at mosque level. We also purchased some of other, we call them motivators or facilitating items like umbrellas, t-shirts, and bags. We also developed kutubas. Kutubas are the sermons that are used during Juma prayers. So we developed 20 kutubas on 20 topics on HIV, addressing the 95, 95, 95. So when you look at those kutubas, they start from prevention, treatment, up to viral load. So these topics were developed in consultation with the Office of Secretary for Religious Affairs of the Uganda Muslim Supreme Council, and they approved them as relevant to the cause. We conducted orientations for the health unity management committees and facility managers, because we believe you cannot mobilize the communities and then when they reach facilities, the work does not coincide with what is coming out from the community. So we engaged them to make sure they are aware of what is happening, and surprisingly, especially in Butambala, we were in a performance review meeting at mosque level last week, and the in charge of Butambala told us for him he has been seeing numbers increasing of people testing, those who go to seek services, especially for testing, and some people being referred from the religious leaders, and he's seeing a trend, an increasing trend of numbers going up in terms of HIV testing. So we believe this is a good start and we are right on spot. We also trained those 108 imams. You can see the pics. The first picture was taken from Kampala. After the training of imams and their assistants, we gave them umbrellas, bags, and notebooks. You can see them in the first picture. Then the other picture, we are distributing in Wachiso. That is Masjid Abdallah Jokolera. We are distributing some of these materials. Then this one down is in Iriantonde. The training happened at Iriantonde Muslim Hall, Muslim Center Hall. So we are still distributing some of these items containing key messages, because we also disseminated the training guidelines and the kutubas. So these were our imams receiving some of these items. What has come out? This is between July 31st and 26th September 2021. This is what we've seen in terms of activities. We had a vigorous 2 months because we believed we had to do something, and our imams to show that really work is there. So in total, we've reached 7,000 people in terms of sensitization, community mobilization, and the education. These were mainly done through ziyaras, darasas, and dawah. So our imams, instead of waiting for mosques to be opened, they preferred ziyara. Ziyara means visiting. They do home visits to the families and educate families. Darasas is education. Some have been establishing some small groups and educate, sensitize people in small groups, especially on border stages, especially the naibu imams, the youth leaders at mosque level. They have been doing that. We've tested 923 people for HIV using test kits. Yes. We managed to find ways of getting testing kits through liaising with the HTS focal person here at UCMB, Madame Christine. She gave us some STKs. We also worked with the districts. We found ways of getting these STKs because we realized the supply was extremely low, yet the demand was extremely high. So some facilities also had STKs, which we scooped, and we managed to get those numbers. As you can see, we identified 28. I had to go and verify this data myself because we needed to know. And in a comprehensive report that's going to be shared to UCMB, we shall see where all these clients are in terms of treatment, or already on treatment, or newly identified. So out of those, we had 28 positive, and then 17 were males. We had 11 females, and then 1 adolescent who is 19 years. It represents a yield of 3% when you try to calculate everything there. What have we learned? That at national and sub-national level, it is very easy to leverage on virtual platforms, especially when we had the second lockdown. The second lockdown really affected our activities, but we found ways of working around the clock, especially at regional and national level, where we engaged the FCI community supervisors to try and monitor some of the activities that were being done. But at that grassroots level, it's very, very difficult. You see, we work with our Emirates, the youth at mosque level. It is really cumbersome to start telling them over Zoom meeting, emails. But at national level, it is very easy to leverage on some of these new platforms. There is need to strengthen the collaboration between religious leaders and health facility managers. What we've seen is that when you have the collaboration between the technical teams and religious leaders, work becomes a bit easier. And all the cases that were identified actually were linked between the VHTs and the religious leaders. That collaboration was really seen. Then religious leaders play a very significant role if they are empowered in averting some public health threats. If they are empowered, they are very much willing to take on some of these health threats. Positive relationship between Muslim leaders and health workers strengthens health service and care for the sick. Yes, because what we realized when we had just went there, most of our religious leaders were really begging for information, merely begging for information, and we believe if we empower them more, things will get better. The best practice, one of them was mainly during linkage, because this linkage was very cumbersome for our leaders. They could identify someone, but convincing them in a medical way to go and seek services was a problem to them. So we connect them to the VHTs, and all the 28 cases, I went to them and really asked one by one case. And the experience is that they contacted the VHTs mainly, and some went for facility in charges. But that collaboration was seen, and it is proving to be reliable in terms of linking these clients to the next destination. Imams and their assistants, especially the Emirates and the Naibu Imams, have embraced the use of STK more than anything else. The questions we get mainly pertains that particular component of this community intervention. And most of the activities done are dominated on HIV prevention. We have some GBV cases that have been identified, but these ones are still resolved at that level. We have a few GBV cases, as we shall share in the overall report for this year, where these GBV cases have gone. Challenges. The first one was the lockdown. This one slowed down our activities. We had to do most of the work virtually, but as you know, faith and community initiative activities are very hard to be implemented at community level using virtual platforms. So we had to wait until it was eased around end of July. And most of the outputs we are seeing here are for those 2 months, mainly August and September. Then there is a delay. Supply chain hindrances for STKs really disturbed us, and we had to find ways of making sure our religious leaders are not frustrated. Then logistical challenges also delayed some of our activities, especially some of the tools that we had to wait to be used in monitoring, especially the FCI monitoring tools. We had to wait until when we improvised, and lucky enough, we had the design with us. So we printed locally, but these ones can easily be lost. So we believe the printed forms will be more durable and will be better to use in monitoring some of the activities that we are implementing. So we treat, it is Allah who has the mandate to heal. So as you can see, this was the team that was oriented at Maria Flow. We can see the district health of, in the middle, the district health of Masaka. He was the host, so he was in the middle, Sheikh Chiruta. Then we have the district health of Greater MPG and Lyantonde. We have the county sheikhs of Lyantonde, Bukoto East, Chibibi, Kabasanda. And the facility leaders, you can see Hajat Lyantonde there. This was taken during the training of these leaders for FCI activities. I thank you very much.
Thank you very much, Dr. Mzamir. Before you leave the platform, there's just one question from Anthony Moviru, who's asking that was screening done prior to HIV self-test kit distribution?
Thank you very much for for that question. First of all, I would like to make it clear here. I'm not yet a doctor.
Oh.
So, I'm Zamil Chivumbi, the M&E manager for Uganda Muslim Medical Bureau. Yes.
On the way to being a doctor.
Very much likely. Now, for screening, yes, our religious leaders were taken through the entire process for when and how and who to give this test kit. The questions were given to them in a lay form that you first ask some of these questions that on the screening tool for HTS. So the questions were given to them in a lay term, in Uganda to be precise. So they know, they first screen these people, and then they give out the what? The screening tool. The demand is too high for these kits. That's one thing I can't stop to echo out. That even if they are screening, but people who need them, especially the priority populations, these border guys, when you go to Lambu, that area of Bukakata, so we have so many fishermen. They are called fishmongers. So you can imagine the demand that is there. As you've seen in the massacre, they carried out 286 tests in just 2 months. Thank you very much.
Another round of applause for Mzamir. Thanks for that correction. We thank you, Muslim Medical Bureau, for that experience sharing. And now we'll move on to the Orthodox Medical Bureau. And allow me to invite Father Sempija to make a few remarks before we listen from Rehema on behalf of UOMB. Father Sempija is the Dean of Luwero Diocese and would like him to make a few remarks on behalf of UOMB before we listen from Rehema. Thank you.
Thank you very much, dear members. Good afternoon. I'm Father Antonius Sempija, as earlier alone introduced by the moderator. I'm the Dean of Luwero Deanery or Diocese, and as well the parish priest of St. Antonius Orthodox Parish. My work is just simple. I've told you to give a simple brief about the FCI projects as it has been done in our deanery, that is in Luwero. I first of all want to thank the parish priests that they have willingly availed themselves to participate in the struggle or the fight of these twin epidemics. I call them myself twin epidemics because wherever there is a HIV, AIDS, it is very simple to have also domestic violence against children, against men, and against women. So that's why I call them twin epidemics. Some good achievements have been observed, like after identifying the eligible people, but let me try to say this, that it has been very difficult to make screening. Like myself, when I was once at the occasion, it was a burial ceremony, and I was given chance to say something. Then I opted to use this opportunity to say something about HIV AIDS and this self-testing as we went through the training. So I tried to introduce all this to them. But after that, many people after the burial ceremony said, no, oh, Father, wait, don't go. You talked about this. What do you want it to mean exactly? So as they had self-testing, many of them wanted to do it. However, if you wanted to screen them, say, no, Father, I'm eligible. You see, this is what they wanted to see. Father, you don't know me. Why do you say, you go there? So it was very difficult to screen those people. When you talk about self-screening, you find that most of them, even those who are hiding a little bit, because you never know, many people do their own things secretly. So when you say that there is chance for someone to test him or herself, you find that all the population or all the people, they are eligible of self-testing. I want to thank also the initiators for engaging the religious leaders in this fight. This has given us opportunity to meet different people in hard to reach areas. Not only it has helped to develop the health status of some other people, but also the spiritual status of people, because it has created the opportunity for us to have time to sit with these people and discuss issues of earth and these issues of spiritual benefit. I want also to thank the religious leaders. I already said this. There are some challenges that we have found, like many of people they have been saying here. But before those challenges, I want to thank Council Semwanga that they availed themselves, the Catholic legal team. They availed themselves to us that whenever we find some cases that needed legal advice, they availed themselves for us to utilize them. There is one of the challenges that I've found that there is high demand of self-testing kits. Like many of them, they have said this already. Unwillingness of many to test. This is also a challenge. You have to struggle so much to take a man to the hospital. Due to COVID-19, generally, patients develop fear to access medical facilities, in fear that they will get COVID from there. So it was a general challenge. Even up to now, it is still there, that people do not even want to refer someone to the medical facility, doesn't want because he fear to get COVID from there. Lastly, I want to mention that the tongue or limi abavubuka lwe bakozesa, the tongue that the youth are using these days is very difficult for the grown up now to understand. Let me tell you, like one day I was going somewhere, even my colleagues mentioned this. I found a man, a youth, he was selling something. And I was going somewhere, he said, hello, I'm selling battery charger, power bank. Then I said, I don't have a power on my phone. Then I said, I could buy some power bank. Yeah, it's 1,000. It's very cheap. I said, okay, come. Can you give me one power bank? What he gave me, I couldn't tell. I don't know even how they call it. But the language that the youth are using, maybe we need to be trained some more skills of how we can handle the youth. Thank you very much.
Thank you very much. Another round of applause for Father. Thank you very much, Father. The power bank. Ladies and gentlemen, let's now hear from Rehema, who will continue for UOMB. We've heard it straight from Father's mouth. Deep in the community, these are the challenges that we are facing, but we will go around them. Yeah, Rehema, you're welcome to make the second half of the presentation for UOMB. I request you to be very brief, 5 minutes, because we just have a very short time to wind up this meeting. So please summarize. Thank you. You're welcome, Rehema.
Thank you. All protocols observed, good afternoon. In absentia of the Executive Secretary, Dr. Sande, from Uganda Orthodox Medical Bureau, I'm Muluya Rehema, and I'm the project. Thank you. I'm Muluya Rehema, and I'm the project officer for Luwero Ordinary. So I've been the mother of this child in Luwero, and I can say it's been a great journey. We began officially in April. We were brought on board in March, so we began officially project implementation in April. Uganda Orthodox Medical Bureau is a faith-based organization that has the mandate to accredit, train, and also we have so many facilities under us. We do strengthening of their health systems. We do capacity building for governance and so many other things. So that is the background of FCI, and everyone here should have gone through the background. It was a 5-year project funded by CDC, an above-site project. I'll not go through all the details, but it was given to 2 recipients in Uganda. That is the Uganda Episcopal Conference and Uganda Protestant Medical Bureau. So we got a sub-grant from Uganda Catholic Medical Bureau, and we're very thankful. It was a non-targeted project. So the purpose of this project was to engage faith-based organizations in a network to rapidly increase the proportion of men and children living with HIV who know their HIV status and are linked to care, and also to ensure the justice of children. Those are the target populations, and I will look at where there is low testing. We are looking at the men and boys, and also the children and adolescents, and those are what we have been targeting in the Faith and Community Initiative Project under Luwero Ordinary. Some of the planned activities we had planned to do in this project in the work plan that we submitted to Uganda Catholic Medical Bureau. Those are some of them. They've told me I have a short period of time, so I'll not go through the planned activities. What we implemented, we did a rapid assessment of the orthodox structures on the HIV epidemic. We went and did a mapping of all the parishes, where we were able to get 14 parishes throughout the whole of Luwero Ordinary. And in these parishes, we were able to get 2 champions, that is a parish priest and another person who was supposed to be the carer, community carer, to be able to facilitate that parish. So in total, we have 28 champions in Luwero Ordinary. And some of the challenges we got, because as you say Luwero Ordinary, that is the structure in the church structure. You'll find that this dinary stretches through Luwero district, Nakaseke district, and then Wakiso district. But that is all under Luwero. So it gave us some structure challenges in the boundaries and which districts to engage. We also we had a meeting with the leadership in Luwero district. We engaged the DHO, Dr. Nkanwa. We engaged the HIV focal person. We also engaged the implementing partner, that is Mildmay, where we met Dr. Andrew. And we were trying to engage them so that we can be able to get HIV self-testing kits. While engaging these different stakeholders so they could help us in better implementation of the project, we also had so many challenges, where you find that Dr. Andrew told me most of their test kits are attached to certain targets. So they found it difficult to be able to avail us testing kits to do the project. We went ahead to do orientation of the Mothers Union, the youths, and the men's fraternity on differentiated service delivery. This was done at Monde, that is the dinary head, that is where the head of the dinary is. We were able to train 40 participants from the 14 parishes in Luwero. These entailed the people, different representatives from Mothers Union, the youths, and men's fraternity. And these people were well trained on how to counsel on HIV, HIV self-testing, and also the screening before you go into HIV self-testing. After that, we went into orientation of the Metropolitan Council and Dinary Head. This was done in partnership with Uganda Catholic Medical Bureau, who gave us trainers and were able to train our Metropolitan Council with the head, the late Archbishop, John Alwanga. Moment of silence, may his soul rest in peace. We did a training of the Orthodox, the Metropolitan Council and the Dinary Heads, and this was attended by 26 participants, representing all the different dinaries in Uganda, and also the people who sit on the board and the Metropolitan Council. We were asking them for their support and also to be able to champion implementation of the FCI project. We did a mapping of the health facilities because this was to help us in referrals and linkages. And while doing this, we visited 16 health facilities. In Luwero, we have 3 PNFP facilities under the Uganda Orthodox Medical Bureau. We also had linked one Protestant facility, that is Chiwoko Hospital in Nakaseke. We also had 2 Catholic under Catholic Medical Bureau, that is Holy Cross, Chichusa, and Basil, yes, Bishop Basil in Kasana, Luwero. But most of the facilities we brought on board were government health facilities, because you would realize that the distance to some of the PNFP facilities was quite far, and people could not be referred to those facilities because of distance. For example, for someone from Chichusa Parish to be able to access Holy Cross Chichusa, it's quite a distance. So those are some of the challenges we received. That is why it was hard to do referrals for some of these facilities. We did a mapping of the drop-in testing points, and I'm lucky to say that right now we have operationalized 2 testing centers, one that is chaired by our dean himself, that is in Monde, and another one is in Degea with also another parish priest. These priests were able to do priest-led home visits in mapped out most at-risk areas, and those were able to bring in numbers in mobilization, because you'll find that as a result of the lockdown, we're not able to do a lot of mobilization, and also the fact that the Orthodox Church is a smaller community. So we're able to link our champions to the communities. They engage the LC ones, they engage the different people. The summary of the mobilized persons you see here is a summary that dates back to a month ago, because we have had in more numbers trickling in. But because of the short notice, I thought we were just in attendance of workshops. I didn't know we had to make a presentation. I did not update the numbers. So these numbers have doubled. But one of the challenges where you see, as I was listening to Mr. Sechimpi, he said Luero, our testing rates were low. We got a lot of challenges. We had very big numbers in mobilization, bigger than the numbers I'm showing on the screen. But the challenge we had is that of testing kits. And as you see the summary there, that is dated back like a month ago, 77% of the people, that was before we went into lockdown, they wanted HIV self-testing kits. When we went into lockdown and they started confirming numbers in the different facilities where we're supposed to send these people, these numbers changed to almost 99%. No one wanted to be referred to a health center. No one wanted to be associated with a health center. Whenever they confirmed a case in that health center, people shunned away from going to that health facility. So imagine a scenario where you do not have HIV self-testing kits and people do not want to be referred to these health facilities. So we got a big challenge in that. Actually, I remember when we had a review meeting that was a month ago, we're talking about these challenges, but they keep saying when your challenges come, you have to find a solution. So what we have been doing this whole month is solution finding, and I'm happy to tell you that on ground now, we are going to have a lot of outputs for this month. We procured promotional materials for our champions. They got t-shirts, they got bags, and also umbrellas. And they're using these things well, and they're able to help them be identified better in the communities. We also sent out bulk messages to the faithful. We did 4 bulk messages, and these were to tell them about the different places they can go to for HIV testing, and also self-testing messages. We have done monthly meetings with the parish champions. We even have one this Friday that is going to be closing our quarter before we can report, because this will be helping us get all the results for this month. We have done community dialogues that I've chaired myself. I go into the communities. We work hand in hand with the LC ones and the champions, and we have held intergenerational dialogues and so many other things. So I remember correctly when I was discussing, we have had so many activities I may not be able to finish, because I'm sure we have gone through our entire work plan as submitted to Uganda Catholic Medical Bureau. Right now, what I can assure you is the last time I talked to Mr. Sechimpi, we had issues of big numbers of mobilization, but little outputs. So I can confirm that by this month, I have distributed over 300 testing kits, HIV self-testing kits. And as just of this week, I have over 25 people who have tested positive. What I'm doing right now, actually I would not have been here if it was not important. I'm supposed to be in the field looking at follow-ups and linkages to see if these people are actually first-time testers or people who have actually known their status. Because the challenge we are facing in the communities, people are excited for the HIV self-testing kits. Even those who are positive, you find someone wants to test, is it true that this kit works? So those are people who will be lying to our champions that, no, I have never tested, so when they test positive. So I think we should devise mechanisms to be able to screen out such people. We have the mild May screening tool. It was given to us by the mild May team in Luero. All our champions have it. So before you test someone, we have photocopied these tools, and they're able to screen each person they're going to test. But then again, people are smart enough to sometimes go through the system. So we have done testings, and I can confirm that as of now, I have 3 cases, positive cases in Sambwe, 3 cases in Kalagala, 8 in Magoma, 3 in Monde. And for parishes where we could not get HIV self-testing kits, we have opted to do outreaches. I was in one actually in Bulami, that was early this week on Monday. We carried out an outreach, a community outreach in Bulami, that is St. Spirian Orthodox Parish. We tested over 50 people, and I can confirm that we had 9 positive cases. So what we are doing right now is trying to see that these people are linked to care and we see that if they have made it to the facilities, the only challenge we have is we did not have a memorandum of understanding with the district. Whereas we engaged the district, they had asked us to have a written memorandum of understanding with these people. So without having a memorandum of understanding, we have had challenges of sending people, where we have sent people on referral and in charges have sent away our people. When they go there for referral, they are sent away. So I was hoping if this project is to continue on, can it be the first line of duty? Can they have a memorandum of understanding? For example, with Luwero Dinari, we are in bed with Nakaseke district, Luwero district, and Wakiso district. So can we have a memorandum with all the districts in place so that when we send, for example, one of my parishes is on the border of Luwero and Wakiso. So when we sent our people, before we could get the self-testing kits, we sent them to Tikalu Health Center 4. And the in-charge there has continuously sent away our people because we do not have, and I understand where she's coming from, because she wanted a letter giving us permission to work. And when we engaged Uganda Catholic Medical Bureau, they told us they were given permission, but they had not hoped in the beginning that they would be working with government facilities. So for bureaus like us, young bureaus like Uganda Orthodox Medical Bureau, where we do not have so many facilities, it becomes a challenge to refer to only PNFP facilities. So we need to be on good terms with the government facilities so it makes work better. But I am very positive that just with the 1 month we have had self-testing kits, the results have been tremendous. So just imagine we had these kits in April. We'd be talking about so many people who have tested positive. If in 1 week I am getting 25 cases, how many can we get if we had a very big, because now I gave out on average 25 testing kits in the 14 parishes, which zeroes down to over 275 kits all through Luwero Dinari. If I'd had the same chance months ago, we would be talking about very many people who had been screened out, and we would have gotten better cases. So I want to thank Uganda Catholic Medical Bureau for giving us the chance, as a young bureau, for giving us the empowerment to also to carry out this activity. And I think we have, I will not brag, but I believe we have tried our best. And I would also want to thank our parish priests, most especially the Dean of Luwero, Father Sempija. He has been there in all the activities. It doesn't matter how small, he has not missed any of our trainings. And also he's also a foot soldier on the ground. He has done screening himself. He actually has 3 cases from his parish that he has tested himself. He gave them the self-testing kits himself. So which says a lot. By the time we have someone as the head of the deanery being there, and the fact that he was there, no parish priest in Luwero was not on board. The fact that the head himself was there to foot soldier this. So I can say, given chance, we can do better. Thank you so much.
A huge round of applause for Rehema. Thank you so much, Uganda Orthodox Medical Bureau. This is very encouraging, and it's good to see yields as high as 18% from your testing intervention, which shows that there's a lot of work still to be done, and if we better target, we can get the missing cases. Thank you for that sharing. I would like to move on to our next presentation, and I would like to welcome Dr. Henry Mwesezi, who's going to take us through some of the materials, the content that has been developed by this project to create demand, sensitize the public. And Dr. Henry is going to make a 2-part presentation. He has products and messages of hope, and he also will talk about engagement of religious leaders in epidemic control. As we are winding down on this forum, we are nearing the end. Please stay with us, especially our attenders on Zoom, and we should be winding up shortly. Dr. Henry Mwesezi is the Deputy Program Manager for the FCI project. You're very welcome to present.
Thank you, Chair, and good afternoon, everybody. I'm Mwesezi Henry. I work with UCMB, and currently I lead the team in Masaka that is working with the Rakai Health Sciences Program for our HIV comprehensive care that we do in the Masaka region, but for this particular project, I do that part, we call it programming, the design. How do we plan? How do we see things moving? And as you can see from this FCI project, it is it is a project that uses a lot of partnerships. And to us, I think we would be proud to say that the partnerships that we factored in within our design have indeed worked. So this has been at the pilot level. It is a seed that is germinating because we have just done it for 1 year, and it is interesting to see how we have been able to marry all people from different denominations that we have worked with, and to see the involvement of the various religious leaders in HIV epidemic control. So we are glad to our partners, particularly CDC, that had faith in us to give us a project which is also faith and community initiatives that gives messages of hope, and therefore to empower people to have faith that things work. So my topic is to deal with the products and FCI, the products and messages of hope. And the bulk of the products we are talking about have been mentioned by each of the presenters we have had today. And since I have only 5 to 10 minutes, I think I should do, luckily enough, a lot has been said. So I'll just quickly rattle through what we've been able to do and to produce. And as the team is organizing, so products and messages of hope, this is what we did. And so this, I'm just talking briefly about the process and the process we used and the materials that we adapted from the FCI Secretariat website. The IEC materials and branding materials that we are designed by UEC, and luckily enough, I think we have already seen these. And the materials and products from our sub-grantees. I wanted also to talk about the MOH and other partners. They also developed materials, and we are also been using them. And then we also want to talk about the mass media engagements and the challenges we've had in information dissemination. So in terms of adapting materials from the FCI Secretariat, we obtained several FCI materials from the website, and we held several discussions with the SBCA, and this one is the Social Behavior Change Activity. This is the communication partner funded by USAID, but helping all the family implementing partners to come up with materials. And so they did a lot of also downloading of these materials from the website. We thought that whatever we have on the website will work, but for the Ugandan context, they selected a few. So SBCA zeroed on 6 posters, and we had several discussions on these ones. So there was, they did fast tracking, and we have to thank them because we had preliminary approval of those 5 posters so that we are able to use them during this project. So the messages on the posters were later translated into voice and again on the posters, and they were also played on several faith radio stations. And then we still used some of this information for interpersonal communication by the parish priests and community carers together with the religious leaders. So these are some of the materials that we picked from the Secretariat, the FCI Secretariat, and then in terms of prevention, these are the particular ones that we zeroed on. For example, bring hope to your family, and so encouraging taking HIV treatment as prescribed helps a woman to prevent transmission of HIV to the child. So the aim is that let this message be passed on by somebody who is trusted, and that is the faith leader. Strong men stand together. The design of the project, like Ron told you, is largely about finding the missing men, the remaining men, the children, because that's where the big gap is. And it is believed, and indeed it has been demonstrated here, that the religious leaders have the capacity to convince even the men. So these were the materials that the Secretariat had developed. These are several countries. I think there are around 10 countries that are implementing the FCI initiative or project. And so the materials that had been developed were also adapted by the Ugandan system. So you can see the logo of the Ministry of Health, meaning that this had undergone approval by the ministry. So in terms of encouraging testing and also PMTCT, these are some of the materials, again, that the faith leaders agreed upon that, well, let us speak on this. Your family's hopes and dreams are worth living for. So it stretches hope. Don't lose hope. You have dreams, you have hopes, and the religious leaders are the best placed people, I think, to pass on this message. Because even going to heaven is premised on hope. You are going to die, but you will hope that there will be resurrection. So the people who preach, practice hope are the religious leaders, and they are the best that we can. So take charge and test for HIV. My reasons for getting an HIV test is for my partner, my family, my community. So get tested for HIV. And now this other one reinforces starting treatment and maintaining yourself on treatment. So this poster was designed to ensure that the religious leaders encourage people to remain adherent to the treatment. So my reasons for staying on HIV treatment is for my partner, my family, my community. So what is your reason to start treatment and stay on treatment? So these are some of the posters that we have developed, and they are being distributed. There was also this Z card that combined a number of things. It was like a pocket guide for the community carers, and it is part of the materials that was approved by the ministry and is going to be disseminated. The other one was about PEP. PEP is post-exposure prophylaxis, and there was also some of the information. And actually, when you look at the community carers and their experiences, they have gone through this. It can be PEP, it can also be PrEP. Because I think when Mr. Migade was giving, no, actually it was Donanta, who told us about discordancy. A man has, the woman does not have. How do we deal with it? And so the religious leaders, if they are empowered with this information, can also talk about PrEP. They can also talk about PEP in cases of REP, because they have been talking about VAC here and so on. So this is how it had been designed, that in case of any of these, the common man feels comfortable talking to a religious leader at various tiers. So these would be the people now, if they're empowered with information, to help out. And this is how we are going to manage and control the epidemic. The last one that was selected was about the HIV self-testing. And it is important that such a poster is in there, because I think everybody who has been presenting here has talked about the main challenge being lack of testing kit, which is self-testing. So in terms of the materials that we've developed, thankfully, these have been displayed here. Apart from me was not putting on a cap, the community carers came with a cap, with a T-shirt, which T-shirt is talking about messages. The bag is also talking about testing and so on. And so here we are. And you also, when you look at what the UCMB has also presented, the umbrellas and so on, all were branded, and they were also still passing on messages of hope. And these are all geared at ensuring that we control the epidemic. I think it was Migade, but also Donanta. They told us that the moment they started putting on a cap, they carry the bag and so on. First of all, they stimulate intrigue. What is happening? What are you now doing? Are you an FDC person? So in other words, there's now ease with which the ordinary man identifies the the faith leader, not only as a spiritual healer, but also somebody who deals with the health. So mensa sana, corpore sana is a Latin word, I think, which means the mind is okay when the body is okay. So even the spiritual health is okay when the body is okay. So when we integrate health care with the spiritual care, we might have the true person. And that will rhyme with the UEC logo and the message: integral development, body and soul. And HIV is one of our challenges of the times, and the religious leaders have a role to play. Probably we took so long to seriously engage them, and that's what they are demonstrating today, that actually they can do a lot more. Father Migadi, Orthodox Church, has just given a testimony here. He's testing, he's doing what? So the HIV self-testing, I think for the policy makers, this is one area where now you had the religious leaders going beyond talking to active engagement in HIV care. The moment they identify somebody who is positive, they will equally tell them to remain on treatment, go for prevention services as the way it was designed. If you are negative, please link to VVMC, link to PrEP, link to whatever. This is how it had been designed. So these are the materials that we used, both for violence against children, testing, remaining on treatment, and so on. And the caps, besides looking fine, you are also passing on the message. So we, in addition, circulated a movie for HIV self-testing. We gave this to the facilities. And we are using the language Luganda. For majority of the people, they understand Luganda better. Actually, I think the English wording we are using is actually to make, I don't know, a gentleman like this one here, Kampala based, I think, to understand it better. But she's coming from Rakai. And the farthest end of Rakai is Ruamagwa. Next, you go to Isingiro district. The bulk of the people who are speaking English that side are very few. Ideally, we should have even our T-shirts in Luganda. But the message will be read and people will act. We have to listen to the grounded people, leave alone, situations like this where we are on a microphone and so on. The real people who suffer HIV, who live with the disease, are down there, and we have to use a language that they pick. So we widely disseminated these to facilities and so on. There are also other materials from the FASTA project, not widely circulated. We required the orientation of the religious leaders on their use. We think in year 2 we are going to implement it better. The good thing is that some of all these materials have been approved by the Ministry of Health. We did partnerships in development of these materials through working with the SBCA, which is the social behavior change activity. And luckily enough, they have developed a lot of IEC materials that have no doctrinal restrictions. I think we all laughed here when somebody said, you distribute condoms and so on. You see, the Catholic Church will shy away a little bit because, it's not a bit. It has its strong reasons why it will say A, B, C, D is not possible. But there are also a lot of IEC materials that have no doctrinal issues with it, and has been developed by SBCA. So all those will all again be used so that our community carers have access to them. The FASTA project by CRS, also Catholic Relief Services, developed a lot of materials which we are going to use. Maldume Uganda for COVID prevention. So you can see, people are talking about, Father talked about double epidemic. I think we might be talking about quadruple or triple epidemics because we also have COVID there, and the religious leaders' roles in that is already eminent. Just look at the news yesterday, I think. People in Kampala said, we are hitting the targets because we have started using the religious places for vaccination. So by the time the religious leader is even giving that space, vaccinate from here, what are they telling you? That please take the vaccine. That already is a powerful message. And there is also a training curriculum in offering actually today, which will be used for community actors. So all these are materials that are going to be used. These are the materials that the FASTA project used, and they fit very well with the community carers, with the other faith leaders and caretakers at the community level. Then for mass media, we engaged the radio stations. In Masaka, we had Centenary Radio. Kampala, we had the Sapiencia for UEC. The Muslim Medical Bureau, I think, had some used Budu Radio in Masaka, Radio Biral, and Salam TV. Then we had the radio sports, jingles, announcements, and talk shows. And then we also oriented media practitioners about HIV, and then messages of hope, just as showed you the pictures. So for Centenary Radio, we had around 480 slots per month in a popular skit. I call it popular because this time around, there is a bit of laughing, but in there, the joke, it is laced. It is intertwined with messages of hope and encouragement. DJ mentions, we had 100 spot adverts per month and 6 talk shows. And for Sapienza, those were the numbers. Oh, I just, sorry. Just for a moment. Can you please play those two?
Swapio, Nanyini Customer Care.
Yes, Munange. Musibe nkoko. Sikyate. Ebijanjalo byaffe bimeze. Gamba bikaze. Kati olwo. Enkoko kazimekete. Ensigo yaffe zinadalindira omwosebo. Essara naye byonna isenkanya eno season. Matia Kasaija tukakane.
Oyabadopio ne Customer Care. Nga kutusibwako Uganda Episcopal Conference nga bayita mu kitongole kyabwe eky'ebyobulamu Uganda Catholic Medical Bureau abakujjukiza nti obulamu kya muwendo ku lw'obulungi bwo n'ab'omu maka go n'ekitundu kyo jjukira okumira eddagala.
Second one.
Tosubopio, Nanyini Customer Care.
Yes, Sylvester, the sole proprietor, aware of my HIV status is a wange sizanyisa siri mukoberenga oli afande manyanga moyimiridde mu nsonga za musenenya.
Abio!
Yes!
Ekisibo tekikukubye.
Banange atamukutte.
Eyo nawe programu ya kawungezi ku Centenary.
Ngamba nawe sibakola be.
Byampaka.
Sorry, is customer care tuleme kukana musintwe.
Oyabadopio ne Customer Care. Nga kutusibwako Uganda Episcopal Conference nga bayita mu kitongole kyabwe eky'ebyobulamu Uganda Catholic Medical Bureau obulamu kya muwendo bukuume.
Right, thank you. So those were the sports, and every other time for them it is like a comedy like a sport. But for us now, at the beginning, at the end, we are giving them messages of encouragement, and all the listeners in there covering 12 districts. So we are hopeful that the messages were taken, but most importantly, that the focus was largely on men. So with that, then you keep on empowering the faith leaders who are down at the ground to even make reference to that in order to encourage men to do the testing. So already UCMB has already told us about the kutubas and the training guidelines. Our partners, the Catholic Center for Legal Aid Services, they also developed these materials. And so what were the setbacks? One, development and approval of materials by Ministry of Health is a little bit of a protracted process. So you keep losing a bit of time, then building consensus on what should we choose, what and so on it takes a bit of time. Then the communication partner was also deeply engrossed in other materials. They had a new new project, new campaign, and a new approach. Theirs is called now Time Up for HIV. And so it took a bit of time also for them to be their side and also do their core side. So due to the COVID restrictions, most of the accessible platforms for airing the messages were also closed. So implementation became a challenge. And then the attention of the listeners, especially at the height of the COVID wave, were more taken up by COVID other than the HIV issues. And then the context itself in which we were operating needed a corresponding availability of health commodities, especially the HIV self-testing kits. So basically, that's what we had in terms of IEC materials. I thank you.
Thank you very much, Dr. Henry, for that presentation on the IEC materials. I think if you have any comments or questions, post them in the chat, but would like to thank the partners with whom these materials have been developed. And one thing I want to also emphasize is that all these presentations will be shared with us so that we can have something that we can always refer to. There is another part of Dr. Henry's presentation. I think this is just the second brief presentation on engagement of faith leaders in epidemic control interventions. And I would like to invite him back to take the podium so that he takes us through. I know we are running a bit behind time, but we request your patience and we apologize for extending beyond. Please bear with us. Thank you.
Thank you, Chair. The second one is about the next steps. I think that's now the major topic that we're dealing with. So as you're aware, what are the prospects for COP21? Tomorrow, we end our year one of the FCI implementation, and there are a number of changes that are happening. And so because of the uncertainties and so on, there are some things I think which by the time I made the slides, a few things even changed. But tomorrow we close year one, and that is the budget period for COP20. So to October 1st, we begin 21. So what is the future? One is that we have a new cooperative agreement with the US government as UEC, and we are fusing the comprehensive HIV care with the FCI project. Previously, we were working as sub-recipients through IDI and through Rakai Health Sciences Program, but come October 1st, UEC, Uganda Episcopal Conference, has its own cooperative agreement, and now that slightly changes the way in which we shall be implementing this project. It has some constraints here, but for now, we shall have to bear. So under the new arrangement, there is fusion of the HIV comprehensive care with the FCI project. We don't have separated funding directly from headquarters as the beginning of 2021. So the resources are just within some realignment. And then we know that comprehensive care in itself is very resource intense. There is a lot of work that has to be done for people you send to the facility to receive their care according to the standards of Ministry of Health. So the interventions of the religious leaders remain very pivotal in the realization of the PEPFAR goals. And so we want to see that we continue engagement with the religious leaders and structures. And for sure, the way this engagement rhymes well and feeds into the community engagement pillar of PEPFAR and the Ministry of Health. Because so far, when we talk about the religious leaders, when we talk about the community carers, these are members, stakeholders at the community level that are helping the country to control and prevent further infections. So the faith structures and platforms are strong foundations for continued demand creation. Everybody was talking about creating demand, and people were listening, awareness raising, support and sustainability of the high impact evidence-based interventions for HIV epidemic control. Some of the high impact interventions are things like HIV self-testing. You can see that even those who were initially scared are now willing to come out. So such an intervention is very important. So the FCI project has built additional capabilities in HIV interventions by religious leaders at various tiers. I mean, we are talking about at a diocese, we are talking at a deanery, we are talking at a parish, sub-parish, and small Christian communities for the case of the Catholic Church. And I think there is a similar structures at the Orthodox Church, similar structures, as Mozamir was telling us, at the Muslim, under the Muslim faith. So we need really to keep engaging the religious leaders at all these levels. And so for sustaining epidemic control, we really needed to keep working together. So what are the opportunities of engagement? This is what we have seen in COP20. So in COP21, UCMB has become, as I've said, a direct recipient of the PEPFAR funds for comprehensive care, and will access some of these commodities like HIV self-test kits directly from the warehouses. We believe this one will be a relief, because previously it had to be through partnerships. You work with the regional comprehensive who gives kits to a facility, and then the facility decides on how to work with the community carers. Now, the same approach will happen, but at least the IP will be UEC, not the community carer. And so UEC will be responsible for UCMB accredited facilities. And UPMB, our sister bureau, who is also working within Masaka and Kampala regions, will also be dealing with the facilities that are accredited to the Protestant Medical Bureau. And then the comprehensive partners will deal with the UMMB facilities and the Orthodox facilities. So these changes have also meant that we make some adjustments, but also address the resource-intensive requirements of the comprehensive care. So to allow for continuation of the earlier model of implementation, we are going to see that we encourage and guide on an intimate relationship between the community carers and the other structures that the health facility was working with. And so, in terms of case identification, because this remains key for epidemic control, the target remains targeting men, children, and adolescents in COP20. So the continuation of the FCI targets and focus remains key. So we still have to be out there in the field looking for the men and children. And then UEC has a sizable number of HIV self-testing targets for which we will optimally target and ensure that the community carers have access to the testing kits. And then demand creation for prevention services remains also high. And then we are also seeing integration of COVID prevention and management by religious leaders. Our call for you to keep supporting COVID interventions as well will be there to complement and galvanize the efforts of the clinical health workers. Then the other key roles that religious leaders were playing, such as adherence support, return back to care efforts, PMTCT, psychosocial support, discouraging faith healing claims, because this is important. Now with this empowerment of faith leaders, I don't think the same priest who knows the importance of treatment is also going to say, well, through prayers alone, you're also going to heal. And so these are some of the things that we are going to continue doing. If we use this slide from the Ministry of Health, they still show a gap. Well, this, I don't know whether this is, how can can it point? But from here, you can see that if we look at ART coverage, children, if you look at the last row, children aged 0 to 9 years, ART coverage is only at 59.9. And for adolescents 10 to 19 years, the coverage is around 58.2. And young persons, it is 20 to 24. And again, for men, if we go to the second one, males 15 years and above, it is at 87%. Compared to the females, where the percentage is quite high. So using the faith interventions, we still have to see that our interventions continue. The design will remain the same. We want to use the community carers working around the faith structure. We have to maintain the faith safe space. But instead of, now we are introducing a new box here. We are having VHTs, peers, expert clients, lay counselors, linkage facilitators, YAP peers. They are going to closely work with the community carers. And then these ones, you link up again with the health facility, and then we shall also continue working with the STTs, and of course, the overall supervision is going to be by the parish priest. However, there is some constraints that a few activities are going to be put on hold, particularly if the project begins tomorrow, after tomorrow, I think we will have to receive some official communication and guidance from UCMB on how this is going to be done. And then we see whether we continue with the whole package as we've been doing it under FCI, or we make a few modifications. So that communication will come. I thank you.
Thank you so much, Dr. Henry, for giving us a picture of what we are going to be working with and how we'll operate come October 1. Ladies and gentlemen, I would like to thank you for staying with us and for actively participating in this Partners Forum. We are going into the closing session. And before we do that, we have next steps. I want to summarily mention that we've been taking note of all the recommendations and requests that have been made by the different stakeholders, and we shall, as UEC, develop these next steps using this information, in addition to what Dr. Henry has just presented. We've listened to all the partners, UGM, for example, the wish for prolonged engagement. All these have been taken note of. The issues of the community carers and their facilitation, more numbers, issues to do with improving linkage, all these have been taken note of and will inform our next strategy. So I would like at this juncture to invite Ministry of Health to give us a few remarks. We have Mr. Edward Kato. Is from the Community-Based Services Division of Ministry of Health. As a community advisor, he's on the call, and I will request him to unmute and give us a few remarks on behalf of Ministry of Health. Mr. Kato, you're most welcome.
Good afternoon, everyone. Can you hear me?
Yes, you're audible, sir.
All right. I want to thank everyone who has participated in this meeting. And I want to thank the different bureaus and the faith leaders who are doing a very good job in the community to support government of Uganda efforts in achieving epidemic control. Ministry of Health really recognizes the engagement of the faith communities, and our strategic direction is aimed at reaching men and addressing violence against children, recognizes the faith leaders as one of the key stakeholders in the community to engage. In that regard, Ministry of Health has developed, and very soon we are launching our community engagement framework, which has 4 pillars. One looks at coordination and collaboration of the different stakeholders in the community. The other one is service delivery. What services do the different stakeholders support in the HIV response? Then the social behavior change and communication. For a long period, the different community stakeholders, such as the faith leaders, have been very key in behavior change. And then how do we use data and monitoring as a key aspect in all the work we are doing? We have also developed tools to support and to work with PEPFAR in recognizing the role of the faith communities. And we want to ensure that we empower them with the skills and the knowledge in HIV so that they do their key roles very well. Some of the key roles we have earmarked to be done by the faith communities include psychosocial support, referrals and linkages, treatment literacy, and community mobilization, which encompasses demand generation and awareness creation. And as I was following all the presentations, it was very clear that the faith leaders have a very important role in mobilizing communities for HIV services. So we are ensuring that by end of this scope, which is in a few days, we want to ensure that we have standard tools that guide implementation of HIV services by the faith communities. And these include the literacy materials, which the previous presenter has talked about, and then a training curriculum. I saw one of the comments that the literacy materials that were developed by FAST have been delayed to be rolled out, but the reason was we want to first train we want to have a training curriculum and empower these religious leaders with enough knowledge on HIV so that they are able to use those literacy materials as the implementation tool. So we are finalizing this training curriculum, and we want to ensure that all religious leaders or all the faith communities from national level, regional, community, and village level up to the lowest cadre in the faith community. A reverend or a priest in my village church is trained in HIV, and they're able to use the literacy materials to do psychosocial support, to do demand generation or community mobilization, to do treatment literacy, and to refer their their congregation or the people who attend the places of worship for HIV services. And all this is geared at achieving epidemic control. I want to thank PEPFAR for leading this, and I want to thank all the bureaus and all the stakeholders who are spearheading this drive for faith community initiative. And let's continue to work together to achieve or to create a better world for our children and also achieve epidemic control. Thank you, and over to you, presenter.
Thank you, Mr. Kato. A round of applause. I'll request you to just turn on your video so that you can just wave to us, if it is okay. We want to thank Ministry of Health for being supportive of these interventions. We are working under the jurisdiction and the umbrella of MOH. So there you are. Thank you so much for those remarks on behalf of Ministry of Health. Thank you, Mr. Edward Kato, under the Community-Based Services Division of MOH. Thank you. At this juncture, allow me to welcome our program officer from Centers for Disease Control and Prevention, on behalf of the United States government, who are making all this possible for Ugandans deep down in the community. Ladies and gentlemen, please put your hands together as we welcome Mr. Arthur Fitzgerald to speak on behalf of CDC. You're most welcome.
Thank you very much. Good afternoon to the leadership of the Uganda Episcopal Conference and Uganda Catholic Medical Bureau, as well as the Ministry of Health and other partners in attendance, all protocol observed. As project officer for UEC's award with CDC, I'm pleased to represent the United States government, the PEPFAR program, and CDC at today's forum. And we thank UEC UCMB for hosting today's forum and for inviting us to share a few words. As I reflect on the past year, I remember some personal challenges that UEC UCMB experienced, including the passing of Mr. Kamara and experiences with COVID-19 that affected UEC UCMB and likely affected many of the other partners gathered today. We pray that these partners and all of us will be safe from COVID-19 in the year ahead. Let us pause to remember the many lives lost and the many people affected by COVID-19 in Uganda and throughout the world these past almost 2 years. PEPFAR Uganda began implementing the Faith and Community Initiative in October 2020, and we are grateful that UEC UCMB has been the leader among partners in achieving impact through the FCI programming in this first year of implementation. We're very proud of UEC UCMB for implementing FCI programs despite being interrupted by lockdown measures such as closing places of worship and restrictions on public and private transportation. We also thank sub-award organizations, including the Catholic Legal Services and the Uganda Empowerment Mission, and also UMMB, Uganda Muslim Medical Bureau and Uganda Orthodox Medical Bureau, who have ensured that the Faith and Community Initiative has reached faith communities beyond the Catholic and Anglican churches. We particularly thank the community carers and the other people on the ground who are doing this life-saving work that we fund various organizations to do. And we thank the faith leaders' openness, enthusiasm, and compassion to participate in the Faith and Community Initiative and to allow this work to happen and to have an impact in Uganda. As was mentioned, we are excited to be awarding more than 1.3 million US dollars in direct funding to UEC, UCMB for the coming fiscal year, which begins Friday. These funds will enable UEC, UCMB to continue to implement and expand FCI activities with faith and community leaders and in faith communities. In addition, UEC, UCMB will be directly funded by CDC for healthcare service delivery in their affiliated facilities in Kampala, Wakiso, and Masaka regions. We hope that funding UEC, UCMB directly will promote the sustainability of HIV, TB, gender-based violence, violence against children service delivery at these facilities. Furthermore, we are grateful to UEC, UCMB for their commitment to providing healthcare services without stigma and discrimination. This means UEC, UCMB is committed to high-quality healthcare access and provision to all people, including key and priority populations such as men who have sex with men, female sex workers, and persons who inject drugs. Through FCI, UEC, UCMB works closely with facility staff and with faith and community leaders. This connection enables UEC, UCMB to work against stigma and discrimination in messaging, counseling, and healthcare service delivery on the ground with people at places of worship, in the community, and at facilities. We're grateful that UEC, UCMB has been enthusiastic about gathering feedback from civil society through PEPFAR's community-led monitoring program and the CSO-developed community scorecard. In the coming year, UEC, UCMB will hear from civil society and users of Uganda's healthcare system, and they are committed to using the gathered information to improve healthcare services as appropriate. We are grateful for UEC, UCMB's enthusiasm and responsiveness to ensure healthcare service delivery without stigma and discrimination at facilities and in faith communities. I will conclude here as the stories and data presented today speak for themselves. Much feedback from today will be very helpful in working with UEC, UCMB to incorporate your priorities into the work plan development, which is currently going on and which we anticipate to be finalized at the end of next month. We thank UEC, UCMB for their progress to date and for their work planned for the coming year. UEC, UCMB's FCI activities are ensuring that people are aware of their health needs and have access to life-saving prevention, treatment, and care services. We look forward to our continuing partnership with UEC, UCMB, and with other partners gathered here in the years ahead. Nuevo Leño.
Thank you so much, Mr. Arthur Fitzgerald, for those kind remarks and for the support that we received from the US government. Fitz Morris. Apologies. Thank you so much, Arthur Fitzmaurice, for those remarks. And ladies and gentlemen, it's been a good journey. We've had a lot of experience sharing and a lot of issues that have been raised. We want to thank you for your attendance and participation in our Partners Forum for the Faith and Community Initiative. As we conclude, I request the Executive Secretary, Dr. Samuel Raj, to give us a parting shot and some words of gratitude as we leave this place. And for our audience on Zoom, thank you for staying with us throughout this meeting. We are really appreciative to all partners Thank you, thank you. Ladies and gentlemen, Dr. Oraj.
Thank you very much. By now, everybody knows what I'm supposed to say because that's what I've been invited to say. I'm not going to repeat all that have been talked this morning, but I cannot help getting back to thanking people. First of all, thanking CDC for having given us the opportunity to design and implement this project. FCI was not originated by us, but contextualizing it in Uganda, designing it here, and implementing it here was done by us. So we really have the nitty-gritties, the components, the tiny ingredients that made it up and made it work. I want to thank also the various partners we have worked with, the sub-grantees, the medical bureaus, the Catholic Legal Aid that we have worked with. I want to thank the implementing partners who we have worked with and we have made input into what they do through demand creation. I'm talking about IDI for the Kampala-Wakiso region and Rakai Health Sciences for the Rakai regional program. I was a little bit taken aback when in one of the districts, the district health officer said they could not supply testing kits to the team from Orthodox Medical Bureau, and yet we know that whatever we were doing, we were helping them actually to reach out to people. We were helping them to reap more on the targets that they were working to achieve. Moving forward, I want to appeal to all the partners that we're going to be working with in the districts to look at what we do as holding hands together to achieve the same goal for the different districts and for this country. This is our country, those are our districts, those are our people, we are part of them. We have to recruit more people. We have to recruit more soldiers to fight the war and join hands together. The segregation of fighting teams will create unnecessary waste of energy in achieving all this. As mentioned already, the next 2 days we're going to be moving into a new arrangement that we work for. And I really want to repeat that the lessons that we have got from this project should not be left to waste, should be drawn in by should be brought on board by everybody. And I cannot help but continue making the appeal to CDC to see how we can make this better, especially when as we go into the next COP, if we can plan to make this better, and also to support our brothers and sisters in the other medical bureaus with whom we have worked. I think the message was very clear from Orthodox Medical Bureau and the Muslim Medical Bureau that the time was short. At the time when we were just starting and things were beginning, to show results for them, we are getting out of there. And I think this can be rather frustrating for them. It would be good to hold hands together with them, and we'll be very glad if we are supported to get back to them. I want to thank the team from UCMB, not just for organizing this forum, but for really working very hard from the beginning, the inception of this project throughout, and engineering the whole thing. As I said, we had a design and build system. So designing, engineering it, and making it work, and all the time thinking, of how to overcome a number of challenges. The whole idea was, can we show results? Can we show proof that this thing actually adds value? The whole question all the time was, can we show that this thing makes a difference? Can we show that it is actually good to have this, even to have it financed? And I think gladly we have shown that it is something good that we need to borrow on even for other interventions when the opportunities are there in other programs, working with faith leaders, working with everybody, bring everybody together, government and so on, and working with them. I can only promise that for us, it's going to remain in our minds to see that we try to push this forward. And I want to encourage that even with the other medical bureaus, let us see how we can, enhance one another, even outside any of the formal arrangements that we have. Our partnership will go. But finally, I want to thank the team at UCMB for organizing the forum itself for this meeting, and thank the hotel and everybody who has made this possible, especially for linking up also with other partners who are not here, who have joined us in a virtual sense. I want to thank you all and pray that we enter into October with energy that we have drawn from the experience of this project. Thank you very much. God bless.
Thank you, Dr. Sam. At this point, I'll request us to rise up, and I'll request Father Sempija, the Dean of Luwero Deanery, to give us a blessing and a closing prayer. Thank you very much.
Father, and of the Son, and of the Holy Spirit, may the Lord our God bless your servants who are gathered here. Thank you for the protection that you've given to us, our neighbors, and all our friends in Christ. We thank you for the opportunity of coming together here that you've granted to us. Thank you for the good-hearted people that you put in front of us, that they have helped the lives of your people. Give us also wisdom and understanding, that we may do everything according to your will. Give us everything that we need in our lives, that you know, because for us we very poor, we don't know even what we need in our lives. But you know, Father, because you are the protector of everything. Through the prayers of our Holy Fathers, Lord Jesus Christ, have mercy upon us and save us. Amen. The grace of our Lord Jesus Christ, and the love of God, and the fellowship of the Holy Spirit be with us all evermore. Amen. May God bless us.
Lunch is served for those at the inter-service hotel. Our Zoom audience, please have lunch in our usual places. Bon appetit, and thank you very much.
We are also hungry, please.
Recording stopped.
Mm-hmm.